Thank you for being here. I'm Armando Valdez. I am a professor in the School of Business. I'm a professor of management and director of healthcare administration, where we started a program to prepare professionals on the business side of healthcare. And so part of what we prepare students for is to develop legislation such as the Affordable Care Act. And so with that, one of the classes I teach is healthcare policy. So if you want to learn more and you don't get enough out of today, please come and take the class. We offer it every spring. Before we get completely started, I would like to introduce Dr. David Savaldi, president of Adams State University. I'd like for him to come up and give some welcome remarks to all of you for being here and taking your time today to spend with us to learn more about healthcare and the Affordable Care Act. Dr. Savaldi.
Welcome. I used to be a speech professor, so I can talk plenty loud when I need to, but it's so good on a beautiful Saturday afternoon in Alamosa to see so many members of our community here to talk about this important topic, and I particularly want to thank Mary Hoffman and Carl Jolliffe. After you told me, Carl, I mispronounced it, for their hard work on this. They've been working, as well as the committee, that the individuals that they work with, to put this together. It's a big task. We're fortunate to have the Community Partnerships Program. We wish that it was one of those areas of the federal government in terms of funding that they would add back, and I know Mary certainly does. I also want to thank our panelists, who are all very, very busy individuals, and for taking time out to come and talk to all of us about this important information. In particular, Marguerite Salazar, who, as you know, has another job, and I will let Professor Valdez talk about her accomplishments, and we're very honored to have her here, and also honored to count her among the many successful alums of Adams State, and her continued support, as well as, of course, Russ and Gigi and Reg and two other folks that I can't remember their names. and there's a reason for that. I have an interest in healthcare because I just got my official old person's card. So I have registered for Medicare, and I'm a little bit curious how the one act is going to interact with the Medicare promise, and I guess that kind of remains to be seen when we get through these, if there is really ever a real debate about budget in Washington, how those things will shake out. But I do, again, appreciate you being here, and I wish you all very well, and we're just, as a famous person once said, pleased as punch to have you here today. So, Professor Valdez.
Thank you, Dr. Savaldi. We appreciate those sentiments and how we bring community together, because Adams State is not just a community, or is not just for educating our students on our campus, it's also for educating our community. And so you'll see the mix around the room today. It includes some students, but it also includes many community members. So I encourage you to network, get to know each other, first of all, the individuals from the community, but also the students as well. We have tremendous talent here at Adams State, and so they're part of our future, as I said before, to develop our future policy. So I encourage you to get to know them as well. Well, we were very fortunate to have a tremendous panel of experts. It's very rare that you can bring individuals who impact our communities and assist with our communities so much, bring them in one group all at the same time. So you're in for a treat today, because we do have 6 very special individuals. Let me introduce them. I do know all their names, but it's because I have their bios right in front of me. First of all, Mr. Tom Deegan. For 17 years, Tom has been a traveling nurse at dozens of community hospitals and distilled his experiences into a book, Healthcare, A View from the Trenches. It's now an ebook available for your Amazon Kindle, so go on to Amazon and grab it if you want to learn more. He writes a blog for the Huffington Post on healthcare matters. Before his entry into the nursing world, Tom studied political science at Georgetown University, and after graduation served as an infantry officer in Berlin, Germany. He joined Robert Kennedy's staff on his return, heading up the volunteer effort in New York for the presidential election. Afterwards, he was drafted by the newly formed Metropolitan Transportation Authority in New York to be their assistant corporate secretary. Please welcome Tom Deegan. So Tom comes providing a clinical perspective for us. So we tried to have as many representative views today as possible. Next we have Dr. Ned Kalange. Ned is the Dr. Calange is the president and CEO of the Colorado Trust, a private grant-making foundation dedicated to advancing the health and well-being of the people of Colorado. Colorado Trust focuses on achieving access to health by investing in strategies to improve health equity for all Coloradoans. Dr. Calange is an associate professor of family medicine at the Colorado School of Medicine, University of Colorado in Denver, and an associate professor of epidemiology at the Colorado School of Public Health. Nationally, he chairs the Center for Disease Control's Evaluating Genomic Applications for Practice and Prevention Working Group and the Agency for Healthcare Research and Quality Electronic Data Methods Forum, and is a member of the CDC's Task Force on Community Preventive Services. Dr. Calange is the immediate past chair of the United States Preventive Services Task Force and is a past member of the Secretary Advisory's Committee on Heritable Disorders in Newborns and Children. He was elected to the Institute of Medicine in 2011. Prior to coming to the Colorado Trust, Dr. Calange was the Chief Medical Officer of the Colorado Department of Public Health and Environment. Dr. Calange, thank you very much for being here. Next, we have Dr. Reginaldo Garcia. Dr. Garcia, who also likes to go by Reg, works with Rocky Mountain Prevention Research Center in its Alamosa office as a researcher and program director with the Colorado Clinical Translation Science Institute as a community liaison to the San Luis Valley. Both organizations are part of the University of Colorado Denver Anschutz Medical Center and are funded principally by the Centers for Disease Control and Prevention, the Colorado Heart Foundation, and the National Institutes of Health and University of Colorado Denver. He is a clinical psychologist who earned his doctoral degree at the University of Colorado in Boulder and is licensed in Colorado and Alabama and is a member of the American Psychological Association. Reg's interests in the Patient Protection and Affordable Care Act are in its provisions for prevention and population health, its integration of psychological behavioral health with primary care and public health services, and his question of whether the Affordable Care Act is truly affordable. Reg will participate in our Talk Straight forum today, representing kind of a preventive and public health perspective. So, Dr. Garcia, thank you very much for being here. Ms. Gigi Darricades is joining us today. She is the president and CEO of Valleywide Health Systems, but she has tremendous experience within healthcare. She's been an attorney specializing in healthcare for quite a while. She was also the director of medical affairs for the Intermountain Healthcare Corporation, director of case mix for Intermountain Healthcare, special projects coordinator, and she has been administrator of McKinley General Hospital in Gallup, New Mexico. She was assistant regional administrator for the Presbyterian Hospital Center in New Mexico as well. She serves as a CEO and an individual who administrates a lot of policy organizations, especially working with a lot of our populations here in the San Luis Valley and especially low-income populations in our San Luis Valley. Ms. Darricades, thank you very much for joining us. Mr. Russ Johnson, CEO of San Luis Valley Medical Center. Mr. Johnson has been the CEO there at the SLV RMC since 2001. As we know in this area, it's our only full-service facility serving much of southern Colorado, not only the San Luis Valley, but primarily the San Luis Valley. He is the chairman for the RPB 8 and as a member of the AHA Operations, Performance Improvement, Circle of Life, and PAC committees. He has been a member of the governing council for the section for small and rural hospitals. Mr. Johnson has served on the Colorado Hospital Association board for 8 years and chaired its Rural Hospital Council for 5. He has served on the executive committee for 4 years and was named AHA's grassroots champion for its day in 2009. A fellow in the American College for Healthcare Executives, Mr. Johnson holds a Master's of Healthcare Administration from Washington University in St. Louis and a Bachelor of Science in Management Economics from the University of Tulsa. We very much enjoy having Russ here. Him and Gigi do a wonderful job of facilitating healthcare for many of us throughout this San Luis Valley, so we're very appreciative. Thank you. And finally, our special guest today is Regional Director for U.S. Department of Health and Human Services, Ms. Marguerite Salazar. Thank you very much for being here, Marguerite. Ms. Salazar was appointed by President Barack Obama as Regional Director for the U.S. Department of Health and Human Services, Region 8, in May of 2010. As regional director, she plays an essential and vital role in the department's efforts to effectively implement healthcare law, especially the legislation we know as the Affordable Care Act. Prior to this appointment, Marguerite served over 20 years as president and CEO of Valleywide Health Systems, which serves the 22 counties of southern Colorado, ranging almost, I think, from border to border, serving over 40,000 patients through 26 primary health clinics. Ms. Salazar is a fellow of the National Hispania Leadership Institute, as well as the Livingston Fellow in Bonefield Stanton Foundation. She was a trustee for the Temple Home Buell Foundation and was appointed by Governor Ritter to serve on the Board of Governors for Colorado State University. She served as chair for the Colorado Humanities and also served on the Board of Trustees for the Nature Conservancy and National Center for Farm Worker Health. She has a master's degree in counseling psychology. Ms. Salazar, thank you very much for being here. I'd like for Ms. Salazar to preface today's discussion with some comments, especially from the Secretary's office.
Well, thank you, Armando. It's really a great pleasure to be here today. Thank you, Mary Hoffman, for inviting me. Thank you, Adams State University, for hosting this, because I think that it's probably one of the most complex and controversial policies that has been passed in a long time. So it's really important, and I am impressed that people have taken time out of their afternoon to be here Saturday afternoon, because I know that people have a lot of other things to do. We're in the midst of probably one of the most significant transformations in healthcare that we've had in probably 50 years. I was thinking about this talk, and I've been doing many this week, but mostly about the fact that April is actually Minority Health Month. And one of the things that I was talking about with Minority Health Month is that 50 years ago, Martin Luther King, as he was talking on the steps of the Lincoln Memorial, said that we are now in a severe urgency of now. He talked about that this period is a severe urgency of now. And I think that now, 50 years later, that's where we are again, in this middle of this transformation of healthcare and what we need to do this year. I last year had spent a lot of time, again, talking about the different provisions and thinking that once the Supreme Court decision was made, once the election was done, that it was going to be a pretty mellow, quiet year. And boy, have I ever been surprised with that. I usually do a lot of talking about my father, who is 90 years old. And being 90, he's got a lot of great healthcare stories to tell. But when I started thinking about the audience here today and what your interests were and maybe the San Luis Valley, my thoughts turned quickly to my 35-year-old nephew, Joseph. And the reason Joseph came to mind was because when his mother was pregnant with him here in the Valley, the place that she had to go for prenatal care was actually the emergency room. And it wasn't because she didn't have insurance. In fact, she had very good insurance, but we didn't have enough doctors at that time who were accepting any new patients. And so, I was pretty young then, and I remember that being one of those moments in time that you remember that tells you that there's something not right here. That my sister-in-law, until, and it was actually at that time that Valleywide and the genesis of Valleywide occurred, and I think Joseph was one of the first babies that was ever even delivered through Valleywide, but that told us a story of what was happening in our country, even back in the 70s. As some of you know, I spent the last 25 years working on finding fixes to the problem of healthcare access and how to pay for it. But each time we opened a new clinic, it was really a stark reminder of the problem that we were facing, that because Valleywide was established to take care of the underserved and the uninsured. And so every time we had to open another clinic, like I said, it was just a reminder that our system was really failing. Now, I don't put the blame on the private doctors, because had they opened their door to everybody who needed care and allowed everybody to walk in, they would have all faced bankruptcy. I knew that, and that was just the truth. But what I did see was the continued and growing problems of individuals and small groups who were trying to buy insurance. And people really wanted to do that. It wasn't that they wanted to be freeloaders. They didn't want to have to show up at the clinic or the hospital and not pay their bill. But it was really getting hard for them to do that. And so what would happen is a lot of small business owners would come to me every year and they'd say, these are the problems, these are the benefits or the plans that have been proposed to us. What do you think is going to be the best one? And we'd sit down and we'd look at them. And Harold Kellogg, I don't know if maybe some of you remember him. I always use him as an example. He had a small grocery store. And he was one of the persons every year who would come in and talk to me about this. So one year Harold came in and said, Marguerite, I can't even afford to buy the least expensive. I can buy insurance or I can pay wages, but I can't do both. And that's what I started seeing. And so people continued, small business continued to drop their insurance, and we continued to open new clinics. And when people talk about the fact that we, 26 clinics in the system, but in a sense, I always felt that it was because our system was just falling apart and we needed to do something. So I spent a lot of time in my career working in healthcare, but nothing would have taken me away from here. This is my home, and I come here as often as I can. I'll never really call any place but Alamosa my home. But then the passage of the Affordable Care Act happened, and I got a call from the secretary to come and to help her implement it. I was an early endorser of President Obama, and I actually met him in 2008. But while I was certainly not looking to leave my job, the position really did fit my own values and my goals, and the idea of being able to take this new policy, because there really hadn't been one since Medicaid or Medicare back in the 60s. And then the CHIP program came about, and that was there, but it really didn't take care of those working families. They were still left out. The parents were still left out. So here was a huge chance to come and join HHS, which is, it's probably, I think it's the largest non-civilian department in all of the federal government. There are 11 operating divisions within HHS. I serve as a representative for Region 8, which includes Montana, North Dakota, South Dakota, Utah, Wyoming, and Colorado. I also represent because the 33 federally recognized tribes, because tribes have a nation-to-nation relationship with the government, so I have 33 tribes in my region. But just briefly, I wanted to talk about CMS, which is one of the biggest ones. CMS is the Center for Medicaid and Medicare Services. We have 100 million insured people between Medicare and Medicaid. It's the largest insurance company in the world. And they are now responsible for standing up the marketplaces, which some of you may have heard of exchanges, and we're really trying to use the word marketplace because exchange doesn't mean a lot to a lot of people. Most people think that's where you put your money and then you never get it back. So we're talking about marketplaces. We have the National Institute of Health, which is one of the largest health research organizations in the world. We've just started doing a huge brain mapping project that I think is going to change the way things happen and how we treat brain diseases. We have the FDA. Colorado and Denver has one of the largest FDA laboratories in the country. And I think people don't realize that 25 cents of every consumer dollar spent on a product is regulated by FDA. ACF, that's Administration for Children and Family. We're doing a whole lot in early childhood development, initiatives, Head Starts, home visitation, all the birth to school issues that are so important. And then SAMHSA, that's a new regional spot here with us, because SAMHSA, which is the Substance Abuse and Mental Health Service Administration, has always been headquartered in Washington. And just last year we were able to get a regional representative, and I think no time is it more important now with mental health parity being part of the law and trying to figure that out, but also things such as the Newtown tragedy that's happened, I think really brings to light the seriousness and how much we need to implement the behavioral health aspects of the ACA. We have huge global health portfolio and initiatives in at least 65 countries, especially in maternal and child health. And we're looking at now at the bird flu. Some of you have probably seen that the bird flu has once again resurfaced in China, and it just points to how important these surveillances are. But I don't think anything is more important right now in people's minds as the ACA. So when you look at the law and you see any law that phases in over time is bound to have a lot of confusion. And I think that's, again, what we're seeing. Because when the law passed, a lot of people thought that they were immediately going to get insurance and be able to have insurance. And so, then some people got increases in their premiums and they blamed the law for that. Anything that happened in healthcare was suddenly the result and the reason, it was the ACA that got blamed. And so it's not really fully implemented till 2014. The Supreme Court decision helped a lot, but then we got into all the rhetoric of which states were going to do Medicaid expansion and which weren't, and who was going to be a federally facilitated marketplace and who was going to be a state-based marketplace, who could do it on their own. But the good news is that over the past few years, we have millions of people who have already been able to take advantage and who have had very good outcomes because of the Affordable Care Act. starting out with over 7 million people who have been able to get back on their parents' insurance. That's a provision that said that we could allow our kids up to the age of 26 to get back on our insurance. We have 70 or 80 million people across the country who have been able to have no copay for preventive services. Seniors are seeing a 50% discount in drugs, and there are many great innovations going on to lower cost and increase quality across the country. This is all really exciting. Prior to the ACA, Americans spent twice as much for health care than any other developed country, and we weren't really better when you looked at our health status. That's unacceptable. Rather than paying for volume, do more things, get more money, there's now a new strategy to help patients who have comorbidities, and we're looking to decrease the number of readmissions into hospitals. I know that Russ is really working hard on that, and we're already seeing a lot of decreases. What we've seen in the last 2 years is the lowest spending in Medicare since it started. We've always seen this trajectory like that of healthcare costs. We're starting to see it actually drop. And in spite of people like Dr. Savaldi, we have 11,000 baby boomers turning 65 every day, and yet those folks are not causing Medicare to be more expensive. We've actually seen a 2% drop in Medicaid costs. We've never seen that. And we're also seeing some of the lowest private health care spending in many years. You might hear some doctors or read that some doctors are saying, I'm going to retire, I'm not going to do this, I can't take it, I'm not going to accept, this thing that's going on. But I really do, I'm in all of my states all the time, I'm talking to providers every day who are excited about what's going on. They're showing me these innovations that they've got in technology, and they're showing me that they really want to be rewarded for outcomes rather than just producing widgets. There's a lot of excitement going on, and I think that these are really smart people, and they go into the business because they want to make a difference, and yet we had the system that really didn't allow them to make a decent living and without having to just see people after people. Now we're starting to look at outcomes and build in efficiencies, get better outcomes. So I think the biggest winners are seniors and children, but also the third piece, I think, is the uninsured. We have more uninsured in this country than any other developed nation. So people who are uninsured were probably going to be the ones to substantially benefit from the ACA. A lot of folks who were opposed to it, I'll say, well, do you have insurance? And yeah, they do. Well then, it's not going to really impact that person, and it's hard for people who have always had insurance to understand what it's like to not have insurance, to delay care, and make your decision about your health status based on the money in your pocket. That's what we're trying to change. Everybody in here today who has insurance, you're paying $1,000 a year additional money to cover everybody who doesn't have insurance. So it's not that they're not getting care. They're just going in the $3,000 door instead of the $100 door. And you know what I'm talking about there. It's the emergency room door. Insuring people is about pooling risk, and it's not really about improving health. And so as we move forward, we're making sure that when you buy insurance, you don't have to promise to never get sick. I was just in Utah last week, and Utah, they were telling me that they're really concerned that the premiums are all going to go up. They're going to go up by 100%. And I'm, as I continued to ask them why they thought that, one of the things Utah did was they had health risks instead of other types of risks. And what they did, if you were in Utah, you were applying to buy insurance, you had to provide 5 years of medical history for you and for members of your family. So as a result, they had a lot of healthy people on insurance, but the people who were sick really weren't insured. So their fear is, well, all these sick people are going to get on, because one of the greatest provisions about the Health Care Act is that no one can be denied coverage because of a pre-existing condition by 2014. So I'm not sure what's going to happen with premiums, but I do know that we have provided millions of dollars to states to be able to do rate reviews. And what that means is that the law states that no insurance company can raise their premium by more than 10% without having really good actuarial analysis to prove that that's what they need to do. So competition is really important. We're seeing a lot of new insurance products being developed. Colorado has a co-op that's going to be available. It's through the Farmers Union. And we think that the competition is also going to moderate the prices. The other thing is that as people worry about premiums going up, remember that we've got the 80-20 rule. And that says that insurance companies must spend at least 80 cents of every dollar on actual health care. Last year, was the first year that we actually started monitoring that in 2010, but last year was the first year that we actually had rebates sent back, and close to $2 billion was sent back to individuals and companies. I'd be talking in a room like this and people would raise their hand and say, I got a check for $40, I got a check for $12. But the city of Pueblo actually got a refund of $445,000 for 1 year's in premium. So we know it's working. And so that's another way that we're going to be able to monitor this supposed increase in premiums that people are so worried about. So as we go forth with the implementation of the ACA, I just, again, want to remind you that the people of Colorado are in very good condition. We're very secure. As I mentioned, my region encompasses 6 states. Colorado is the only state that's going to do a state-based exchange or marketplace. The rest of the states will have a federally facilitated exchange, with the exception of Utah, which is looking at doing a bifurcated system. Only North Dakota and Colorado are going to do Medicaid expansion, which will cover people up to 133% of poverty. And one of the best things about that is it's only going to be income-based. So childless adults who meet the income guidelines will be eligible for Medicaid. Again, we're talking the poorest of the poor. The other thing is that we know it's going to be complicated because health care is and health insurance is. So the law states that we have to have navigators. Every state has to have navigators to help people get through. So last week, the federal government issued what they call an FOA, a funding opportunity announcement, telling all the states who aren't going to do their own state-based market that there is money available for them to hire navigators. So 2 of my states, Wyoming and Utah, are eligible for $600,000. The people in Utah told me, well, great, that's like $1.15 per uninsured person. Well, it's not a lot of money, but just to compare, Colorado is going to spend probably up to $20 million on navigators. They're going to hire hundreds. So, when you think about that, who's going to do better? The state-based exchange or the federally facilitated? So I'm going to stop there because I know that our panel has a lot of really great things to say, but I hope I've provoked a few questions, and we've got lots of answers, or at least a place to go find it. So thank you very much.
Thank you very much, Marguerite. And I thought, as she was making her comments, I thought something very important she mentioned is that it does impact all of us. And it impacts all of us in the manner that even if you do have insurance, there is the possibility of it bringing down a cost because 80% does have to be spent towards clinical care. There could be a possibility for a rebate, so it could impact you. We do have this panel of experts. I do want them to also give their perspective on how the ACA impacts their organizations, as well as they think how it's going to impact their community. So if we could spend 5 minutes with each one going down the line, and then we do want to make this an interactive discussion, we will give you an opportunity to ask questions. Tom, start with you.
Should I use this? Can you hear me? Yes. First, I wanted to ask how many nurses are in the audience. Could you just hold your hand up? 1, 2, 5, 6, 7, 8. Thank you very much. I'm a nurse, and I kind of bring that point of view to the table. Reg and I chose this table. We were the first ones here so that we wouldn't have to be the first ones to question.
Turn this place around, be in the front row, right?
My point of view is that there's a lot of waste in the system as it is. And I wish we had started reform with the signing of the Affordable Care Act to have reform of the existing system at the same time as we had the promise of a new overlay. And I would like to have seen the cost per patient care delivered come down a little bit, so it would have been less painful to spread it out. And I'm really a hospital nurse. I've been a traveler, and by necessity, travelers are called in when the facility is dysfunctional. So I've seen a lot of dysfunctional hospitals. Some of the cost elements that I see are too much paperwork at the operating level and also at the staff level. The staffs of hospitals have grown to meet a lot of federal requirements, which is all well and good, but at a certain tipping point, the staff is sucking the energy out of the facility, and the workers in the vineyard are getting a lot put on their shoulders for paperwork and also being short-staffed to pay for the administrative staff. So that's a problem. The emergency room costs have gone up so much. I think the average emergency room visit is now $1,314. A private doctor's visit is $190, the national average. And the costs have been driven up by a lot of testing, and that is started by the doctors worrying about lawsuits in the ER. One of my campaigns is to get the ERs shrouded in Good Samaritan protection, not the whole system, but just the ERs, to reduce some of the unnecessary testing. So those are a couple of places where I see waste in the system that could have been worked on in preparation for the transition. So I don't want to monopolize the story here.
I don't think that was monopolizing this at all.
Pretty good time.
Because what's what I do? No. So I want to start out, I always like to tell folks that I'm a Valley kid too, but the Arkansas Valley. From Lahunta. And I was telling Russ over breakfast this morning that the coldest football game I ever played was in Alamosa. I also want to start by really recognizing the presence of the students today. I realize that it's a gorgeous spring day in Alamosa after what I know was also a cold, snowy, dark winter. And the fact that you're here with this level of interest in health and healthcare policy, to me, is remarkable. And I want to applaud. I apologize that my generation has messed up the system so much that we're here today figuring out how to use the Affordable Care Act and other approaches to fix it. But my faith is in you moving forward in creating a healthcare system that works for your generation and your children's generation. So I really appreciate you here. And I'm in awe of your dedication, because I would be out there. The Colorado Trust is a private foundation. We call it a conversion foundation. When Presbyterian St. Luke's in Denver sold to a for-profit hospital chain in 1985, the profits created the foundation. And what we do, how we do our work is we don't raise money, we continue to invest those profits and then give away 5% of what we have every year. So that's the way the private foundation, conversion foundation works. We've been at this since 1985. In 2008, Irene Ibarra became the executive director and president of the Colorado Trust, and refocused all the work of the trust on something she called access to health for all Coloradans. And I think this was very admirable, and I had a great deal of respect for my predecessor, Irene, who had to actually retire prematurely due to health reasons, and I came on with this wonderful vision in 2010. But I want to point out that in the meantime, something happened. The Affordable Care Act passed. And so a lot of the things that the Trust was trying to achieve with its funding occurred through national legislation. But I do want to talk a little bit about the projects funded under the Access to Health. One is Project Health Colorado, which gives money to Healthy San Luis Valley program, which started right when I got to the Trust. There are also health integration with the early childhood councils. Again, money came into the Valley for that. There are outreach and enrollment for eligible but not insured, but not enrolled Medicaid children. Are projects that the Trust funded, and then the Colorado Health Access Survey, which I hope you might pick up a couple of the reports we generated, because the report we brought down specifically talks about your region and the San Luis Valley and how health insurance is impacting the people in the valley. So those are kind of work that we've been doing. And I realized that the landscape had changed and that maybe the Colorado Health needed to focus this vision. So last year we went out and did what we called an environmental scan, including a community engagement session here in Alamosa, where we asked the communities what it was that the community needed to work on in order to address one very specific part of access to care, health equity and health disparities. This has been a long-standing interest of mine, especially since my time at the State Health Department, and is now kind of the driving passion for my trustees and the staff. And so we heard a lot from the community, and I always tell Susan, my wife, that the biggest thing I learned was that the community knows what the problems are, and the community knows what the solutions could be. And that me sitting up in Denver, even being from La Junta, thinking that I might know what Alamosa needs to address problems in health equity was foolish. And I really don't like being foolish. So we're trying to turn a new page, focusing on health equity and spending our time funding in 3 areas. Health information, which is things like the health access survey, because you'll never know if you're getting better if you're not measuring. And no one wants to pay for this. I'll tell you, I was at the state for a long time, and no one ever wanted to pay for it. We're going to look at health policy, and I realize that that seems a little far afield from sitting down here in the valley, that anything under the gold dome in Denver could ever be any good. Well, you're probably right, but we're trying to make sure that the policies that are enacted help assure access to health with a focus on health equity. And I still believe that that is important. I also want to point out that there are policies at the local level as well, and how the community in Alamosa and throughout the valley tends to look at policies around reimbursement, engagement of the community, patient navigation with the healthcare system, transportation, education. All of those are issues that have policy implications, and we want to support that. The next area I think we'll be engaging in hopefully next year is coming back to the communities and empowering, maybe not that word, how about engaging the communities and letting you drive the bus, letting the communities drive the bus in designing, implementing, and carrying out projects that would advance health equity in your specific community. So we're very excited about that. And I'll end with leadership. There is a remarkable lack of diversity in leadership around healthcare in Washington, D.C., in Denver, throughout the state. It's not that the leaders aren't there, it's that we haven't figured out how to engage diversity in our leadership looking at health issues. And I firmly believe that if we're going to be successful in meeting the needs of a very diverse state, which I embrace and enjoy and admire, we're going to have to make sure we empower the voices of all the community and all the leaders throughout the state. So what does that have to do with the ACA? The ACA enabled the trust to take this new turn and really focus on a little bit more into a true interest in this specific part of access. The ACA is a good bill. It's not a great bill, Margaret, but it's a good bill. It has faults, and they need to be worked on, and I hope we will. But it does leave out still about 200,000 Coloradans. It does not address the health needs of undocumented individuals in our state, and it still is going to have a lot of support in implementation to create both the coverage and the healthcare system that works for a diverse community. So the ACA went a long way in the trust getting to its vision, and it's helped us change the corner and look at health equity. Thanks.
Thank you. Dr. Garcia.
Good afternoon, everyone. Thank you, Professor Valdez, for the nice introduction, and Mary, thank you very much for inviting me to participate in this panel. And to my colleagues and fellow panelists, I'm really happy to be here with you today. Thank you all for coming this afternoon, and as Dr. Kawan said, on such a nice Saturday afternoon at that, it's not storming and 30 degrees below zero out there. They just had to get out of the cold. I'm really happy to see my support group here. These are my partners in crime who we've been working with for some number of years in research. Teresa Rutter, Julie Geiser, Jenna Akers, Helen Lester, Freddie Huckes, Charlotte Bedomi. Miss anybody? Great having you here. Okay, so I'm supposed to tell you a little bit about what the prevention and public health improvement part of the Act mean for our organization. And we're primarily research organizations. We're not a direct service organization. The Rocky Mountain Prevention Research Center and the Colorado Clinical Translation Science Institute, our mission to improve patient health through research, high-quality research, research that tells us what works in care, what works in prevention. So we have already a lot of studies that we've been doing in the San Luis Valley that I think have kind of put us a little bit actually in a very well-positioned place to collaborate with all of our partners here in the Valley, and I think also with the Department of Health and Human Services, certainly the Centers for Disease Control, and our own universities in Colorado. Let me tell you a little bit about what's in that in the Prevention Act, and particularly the part that deals with research. And then I think in the question-answer period, there's more to it that I will have a chance to tell you about, so that I can stay relatively close to my 5 minutes here. Now, this is a 974-page document, and about 51 pages deal with prevention and public health improvement. I hope that you will all take an opportunity to read this document one of these days. I thought I would never want to do that, but as I've been doing it, I've actually found it very, very interesting. But maybe that's just me. So most of what's applies to research is covered in what's called Support for Prevention and Public Health Innovation. And this provides funding for research to examine practices in prevention, translation, and effective strategies for real-world public service delivery. New federal programs will collect disparities data, and these will be used in monitoring and detecting health disparities trends. The CDC in particular will be required to study and evaluate best employer-based wellness practices and promote the benefits of worksite health promotion to employers. There will be surveillance and intervention grants for infectious diseases. There will be grant support for research and treatment of chronic pain management. And I think that's probably of really special interest to some of our partnerships here in the Valley, especially those involved in the San Luis Valley Prevention Coalition, just because that has just risen to the top as such a serious problem here in the San Luis Valley, both at the clinical end and at the treatment end. And I think has led to people doing some things that maybe they wouldn't otherwise do. There will be childhood obesity demonstration projects funded to develop comprehensive and systematic models for reducing childhood obesity, which, as probably most of you know, is at an all-time high in the United States and Colorado, and even here in the San Luis Valley. So I think we have a lot to offer to the success of the ACA here in the Valley, and let me just touch a little bit on some of what we are already doing. We have several studies in progress now, most by the PRC, some by the CCTSI, and these studies span across the age range, from preschoolers to elders. We have several, we have one study that's called the Culture of Wellness Study at the preschool level, and this is to promote healthy living among, little bitty guys from the very start, from, the beginning of their years. They hopefully will begin some healthier habits and not have the health problems we see in so many of ourselves as adults and elders nowadays. But also as well as among their parents and their teachers, so that we're trying to be, as comprehensive as we possibly can in some ways. We have several studies here in the San Luis Valley going on right now in several school districts at the K-12 level that are dealing with everything from nutrition to physical activity to risky sexual behavior to substance abuse, bullying. These are all things that physically, but also from a psychological and sociological standpoint, contribute to many of the physical health problems and high cost of health care we see later on. And it's targeting students, all staff, marginally parents, but also to make changes at the environmental and policy level, so that schools, for instance, school environments actually come to support healthier behavior, healthier kids. And we're already seeing some progress in that. The CHAMP project provides really extensive assessments, health assessments to K-12 at the beginning of the school year. Most everybody who works on this project as partners contributes to it are here in this room. It's pretty broad-based. It's to provide early detection of problems that will affect academics and other parts of health, and to result in timely intervention, so that we don't have kids going well into a second semester sometimes without having had a problem detected or already having lost a lot of schooling and failure experiences. There's a new part that's going to be tacked on, well, it's being proposed, so that we can start looking at some of that data in relation to such things as even ER visits, school absenteeism. We did then also in a very extensive adult health study in the San Luis Valley, all 6 counties, 1,200 people who participated in it, so that we could come to understand a little bit better what is the health status of adults in the San Luis Valley, some of the risk factors, some of the health behaviors that they also engage in, and how can this data be used by us here in the Valley and actually beyond. And we're seeing it already being put to use in public health improvement plans, in grant applications, and tied to a lot of these things that we're talking about in the ACA. And I'm probably well over the 5 minutes by now. So let me just conclude by saying, and we also are looking at the elder years, folks like us here. What are we going to need? Well, no, not you. Just me. David, where's David? What are we going to need to continue to live in our communities and in our homes, to live healthy lives as long as possible? So we're covering whole age span. I didn't mention a whole lot of other studies that are more focused on particular problems, cancer, asthma, and so forth. So I think we're off to a good start. I think we have the capacities for further additional partnerships to move the needle higher and read the act. I think you will actually enjoy reading parts of it.
Thank you, Dr.
Good read.
Thank you, Dr.
Hi. It's an honor to be here. The Affordable Care Act really ties in wonderfully with Valleywide's mission. Our mission is to provide safe and effective health care services in a respectful and inclusive manner with special consideration for the medically underserved populations. And that is the work that Valleywide has been focused on over the years and for many years that it's been in existence. And so we've been taking care of all populations, those who've had insurance, those who don't have insurance, those on Medicaid. Also, we have a special focus on migrant and seasonal workers. So we work very hard to do a breadth of work with different populations. And we have clinics in many communities, some that are very small. And we do get a grant. We have a sizable federal grant, but that only covers about 16 to 17% of our, accounts for 16 to 7% of our income. And so the rest we have to make through other grants, through revenue, et cetera, and then we manage it like a business. And that's not going to change with the Affordable Care Act. We're still going to have to be very business-like. But I think that the Affordable Care Act is going to hopefully help stabilize some of the financial issues for us. With the increase in the Medicaid populations, for the Medicaid coverage is going to help the hospital, it's going to help us, because many more people are going to qualify for that here in this valley. And so, you know, when we look at a huge population of uninsured patients here, I think a sizable number, well, we know a sizable number, we've been looking at that, are going to qualify for Medicaid. The insurance part, I think it's going to be a tougher one. It's going to be a tougher one to predict. I think some people are going to be reluctant to buy into the insurance until the time when the penalties get to where the premium benefit, et cetera. They'll do that cost-benefit analysis, and that's going to have a challenge. And I think that's going to have a challenge also for the insurance companies, because they'll have, I think, the sickest patients enrolling first, and they're going to have that impact, and the healthiest people will stay off and just pay the penalty. However, people really need to understand that the tax credits and the way that the statute is structured will assist them in purchasing insurance. I think that the tax credit, which is not like we usually are assuming tax credit, it comes up, at the end of the year when you do your taxes, you figure out your tax credits and that all works. This really comes up, and at the time when you're enrolling, that they'll determine what kind of tax credit you're going to be eligible for, and then that goes directly towards the payment of the premium. And that, I think, is going to be very beneficial. And so I think people are going to see, a reduced premium to what they've been facing to this day. But for a while, I think we're still going to have challenges in that area, just because, one, I'm not sure that people really understand how the statute works in that area. So that's an issue. Capital fund, one of the things, with the Affordable Care Act is also, there was funding to help federally qualified health centers to prepare for 2014, when we anticipate seeing many more patients trying to access care. And so we did get funding, and we built a lovely new facility in Monte Vista, and a very good facility over in La Junta. And so we're preparing, for the acceptance of more patients, and for the capacity, or building the capacity to care for more people. We've also obtained other funding, and have worked for the last few years before Marguerite, before even you left. With Valleywide Health Centers, some of the clinics in some of the other communities. One thing as part of our missions, we do believe that patients should be treated and cared for in facilities that are safe, clean, and attractive. Just because somebody's uninsured, it doesn't mean that they shouldn't have this nice facility as I would go to for my health care. So I'm proud to say that when I moved to this town, I went to Valleywide right away, so for my care. I think the Medicaid expansion is going to be, as I said earlier, a big benefit to us, because again, it applies to all persons under the age of 65 with incomes up to 133% of the federal poverty level. And so this will cover children, pregnant women, parents, and adults without a restriction. And Colorado is currently working on this legislation, and we're really hoping it will pass. So I urge you to contact your state representative, Eddie Heel, and your state senator, Larry Crowder. And they are actually supporting it, but it's helpful for them to know that their constituents are behind it. So I urge you to encourage that support. There is also, I talked about the health insurance exchanges. The impact on us is, I think the marketplace for the healthcare provider marketplace is going to be both more competitive, and then there's also going to be opportunities for more collaboration. And that's going to be a challenge, is how do we do that? We can try arm wrestling, but
Just not a game of wits.
So, we're also going to see a change in the style of medicine. We're looking at potentials of moving away from the standard fee-for-service, so that, the only way we get paid is every time you get sick and you come into and see us, then we get paid. We're looking at potential of having, some kinds of global payments. And that'll incentivize us to be more efficient. And for us, it's a good thing too, because we have been providing what we call enabling services, case management services, and helping people determine what their eligibility is for Medicaid. And we'll be pushing more of the insurance as well as we go along. So it'll be interesting to see, you're also going to see that change, I think, when you go to your providers. The other thing is, in changing the style of medicine is this focus on patient-centered medical home. And Valleywide, by the way, is certified as a primary care medical home system by the Joint Commission. And so we're very proud of that. And the effort there is to really work at keeping patients and residents, because they may not feel like a patient at the time, but if they're well, but keeping them with their providers, and so that the provider can say, you haven't been in for your PAP. Times to send you a reminder, and you need to have this preventive service, or gee, you're requesting meds, but you really haven't had a visit. You need to check on that. And doing it so that you keep seeing the same person and the same provider. And one of the challenges we have in a rural community is retaining our providers. Many of them think the life is better on the front range, but you can shop really well on the websites. You don't need to go to Nordstrom's anymore, or Macy's or wherever, but but we're really, the hospital's working on this, and we're working on this, really working hard to try and retain our physicians. But it gets to be a challenge. People think, oh, it's just going to be this, that. But we're really going to work at keeping you with your provider. And there's a pot of providers, so that, if your provider's out that day, there might be another provider who will be there. The other good thing is that we have electronic health records. And so if you come in to our system and you choose to go and be seen in center, your record just is immediately accessible there. And so that's, there have been several statutes that are allied with the implementation of the Affordable Care Act, and one of them really is pushing for electronic health records. By the way, even veterinarians are doing that, but they're not under the Affordable Care Act. I know my vet has, they've been able to pull the record right over to their new practice. So, but there's a benefit to having the electronic health record. However, physicians and other providers moan and groan because, they have to click through this, they have to learn this, new system. And there are some legitimate concerns with some providers who may be older and who may have dexterity issues and things like that, but there are ways of addressing that in the systems. But the electronic health records is wonderful. And then, health information exchanges. So you live in Alamosa and you're treated in Alamosa and you have a massive car wreck or a coronary in Denver. We're working on systems to be able to provide that, just get the data across. And even with the electronic record, and I see somebody laughing, that's probably because we're not participating in it right now, but I'm glad we waited. And then the big challenge is going to be educating patients. So, and a big thing is integration of healthcare services. And this is something Valleywide has been working on for a long time, but having the scope of services, behavioral health, and I know the hospital has been really beefing up their behavioral health services. I see one of them here. Dental services, physical therapy services, public health, and starting to work with that. And then we also have different accountable care organizations. I think one of the challenges is that I would love to see more sort of unified accountable care for everything rather than here's Medicaid, here's Medicare, what we do with private insurance, but really moving towards a uniform system. And, that's a little bit of arm wrestling right now as we work on it, but we're working on it. So, these are the challenges we're facing. It's an exciting time, and it is an incredibly busy time, Marguerite. You're right. It's just nuts. So, and I seem to sort of have to, our staff, we're always on the road, it feels like, and, trying to work in different places and get the stuff done. But we'll get there.
I already consider this a success because there's more people in the audience than on the panel. So I thought that was a good sign. But thank you for being here on a Saturday. I'm between you and your questions, so I'm going to try to go really quick. As a hospital, I think there are 3 primary components to the Affordable Care Act, and Marguerite may clear me up on this. But I see them as insurance reforms, increased access, and frankly innovation, which might take you a little bit by surprise. So how do those affect us as a hospital? And I think we usually go back and forth with Adams State as the largest employer, but I think you guys are in #1 right now. But in terms of the insurance aspect, it definitely has an impact on us as an employer because it gives our community of people, our employees, more access to care. And frankly, even though we offer a subsidized health plan, there are people who may say, I cannot afford that health plan even as a subsidized health plan. And as an employer, you want people who have health insurance if you can, because we know that people who have health insurance are healthier. And interestingly enough, on the insurance side that Marguerite laid out, those ideas, we knew those a long time ago. And what you saw is the insurance companies implemented those actually ahead of time because they knew they should have. And so I think as an employer on the insurance side, that is a benefit to us. So I'll focus a little bit more on access and innovation. And try not to repeat my colleagues and let you get to your questions. Access is critically important. There are so many peer-reviewed studies that show if you have a population of people who do not have access to care, they have substandard care. And that's just the way it is. So you all know, many of you have been in the Valley for years, you all know the community we serve, and the community that lives here has average household income is half the Colorado average. The uninsured is twice the Colorado average. And we are incredibly lucky. It's not just because I'm sitting between these two. We are incredibly lucky to have organizations in our valley that serve the uninsured, primarily our federally qualified health center, Valleywide Health System. And a lot of communities don't have those kind of resources. So that is a very important foundation of care. But they don't have orthopedists and ENTs and subspecialists. And when you are uninsured, trying to get into a specialist is incredibly difficult. So don't underestimate the importance economically to this valley of having an expanded Medicaid coverage program and frankly, having small business and individuals have access to insurance in a subsidized manner. That is incredibly important. We need people not to use emergency rooms for their primary care medicine. That's not prevention, it's not wellness. It is a stopgap at best. So I think 160,000 people is the estimate for the expansion of Medicaid in our community. That doesn't even count the expansion of commercial insurance in the state, excuse me, not in our community, across the state. So we're talking about hundreds of thousands of people who are delaying or not getting care right now, who will be. So that's an incredible advantage. And as a hospital, it's an advantage, of course, because as one of the speakers said before, somebody is paying that bill. And if you're a small employer now and you're dealing with insurance premiums, part of your premium difficulty is the fact that you're paying for a bunch of people who cannot right now. And we already know through expansion of Medicaid in this state, through the provider fee, that reduces the increased premium of commercial insurance. So I think that's an important piece. So access, I won't say more about that, but innovation, I think, to me, innovation is really the heart of the Affordable Care Act and what makes it important and powerful. And the fact is, you saw some of the charts out there and you've heard the speakers, our delivery system, our healthcare delivery system is not sustainable. It cannot financially be afforded by our country. And so we don't know what the answer is, and the Affordable Care Act isn't alone the answer, but what I see it as is the pathway to the answer. One of the things that a lot of people don't know about the Affordable Care Act, because it doesn't affect them individually or their business, is that it creates a huge incentive on innovation in healthcare, on changing the way, you've heard some of the speakers talk about, the way healthcare works right now is it's called fee for service. You come in, you get a CT, you pay us. You come in, you see a doctor, you pay. And that works really well in some economic models, but it doesn't work well in healthcare, and especially in third-party insurance. And what it ends up doing is creating an industry, now the largest industry in the United States, healthcare is the largest industry. It creates an industry built on volume. So the more we do, the more revenue. Whether or not it may be in your best interest. And that's the fact of the matter. And there's tons of data, the Dartmouth Atlas and other data that shows we're overutilizing healthcare. So the other thing the Affordable Care Act is, it's really generating innovation on a ton of levels, and some of which you've heard from the panel already. It's generating innovation and collaboration and pushing hospitals, which are a big part of the current problem in healthcare. Hospitals are a part of that problem, and it's pushing us out of thinking about ourselves as just doing tests and surgery and imaging, which is our economic model, and looking at more how do we be partners with public health? How do we be partners with our primary care colleagues? How do we get involved in the community more? I think another innovation that you're going to see come out of the Affordable Care Act is you're going to see a lot of pressure on what does it mean to be an engaged consumer. You know, it isn't going to work anymore to buy a health plan and say, okay, I bought my insurance, so I want what I want when I want it. It just isn't going to work that way. And I think we are all going to have to be more discerning consumers of healthcare, smarter about what we have, smarter about what the diagnosis is, a better communicator with our physicians, a better colleague to our providers, and more aware of what the options are for our own care. So I think another area in the way the Affordable Care Act affects us as a hospital is learning how to engage patients and families differently and at a much deeper level, with putting patients at the center of what we do. Frankly, we've kind of put ourselves at the center and said, you know, don't look behind the curtain, but trust us, it'll be okay. And we need to pull back the curtain and put patients more in the center of their care, more accountable for their care, and a lot of other things I think will come down the pike in innovation, but that's my time, I think. Thank you.
Well, it is exciting having all these different perspectives. We have a wealth of experience, tremendous amounts of knowledge on the topic. As many of our panelists were going through their perspective on the impact on healthcare, it made me think about my path with healthcare and how I got into healthcare initially. I was working in northern Colorado for a higher education institution, and I was administering and overseeing several different health programs, and I kept going to meetings and boards and then serving on advisory committees, and I kept noticing around the table there wasn't a whole lot of doctors or nurses. It was people that weren't even actually involved in the clinical aspect of healthcare. And everyone thinks if you get into healthcare, you got to be a doctor, you got to be a nurse. It's not true. You see a lot of the individuals here who are very much involved, and I think it was Gigi who mentioned a business perspective on operating these organizations, because it still comes down to being efficient. It comes down to delivering a good product and quality service for these individuals. So coming to Adams State and thinking that there's an opportunity to prepare a new generation of individuals to work on the business side of healthcare is why we created the healthcare administration program. Teaching health policy for the very first time in spring of 2008, Affordable Care Act wasn't even part of the discussion then. It was prior to the election. We didn't even know what healthcare legislation might even look like. And what we had was predominantly managed care, and we're starting to kind of see a little bit of a transition from a managed care model to the legislation that we have now. I was invited to testify in the spring of 2009 on rural healthcare, and it's interesting to see all the different perspectives that came, that what should be included as a part of the legislation, and then to see what we have now that's providing more coverage. I do want to mention that we wanted to have an insurance perspective on the panel as well, because many of the panelists mentioned insurance. It's a very critical and important part of the process, and as a stakeholder in the healthcare system. Cindy Palmer, who is the CEO of San Luis Valley HMO, she was scheduled to be with us today. She had a last-minute conflict, but we would very much have enjoyed having an insurance perspective as well, because that is an important perspective. But we do want to make this an interactive engagement. We have this opportunity to ask questions of our panelists. So if I could ask my lovely assistant, Carl. Carl, I wasn't expecting the lovely assistant, maybe cue at that time. He's going to be going around and he's going to be passing around some index cards. And I'd really encourage you to take one. And even if you don't have a question right now, you may think of one that comes up as we go through our discussion. And so Carl's going to be able to bring those questions down to me, and we're going to ask them to our panelists. There may be varying perspectives on the legislation. You think it's good, you think it's bad. There may be various perspectives on what you think need to be included. And that's where I was when I went to the White House. You know, I thought I was going to get a lot of what I wanted into the legislation. Well, I was definitely an advocate for universal health care, then I went to the public option, and then I went to the Affordable Care Act. So you don't always get what you want in, but there's a part of what I was looking for in covering more individuals, increasing the risk pools, bringing down the cost. That might be very important. So we're going to be, prior to this, and not just your index cards, we had a blog, and as part of the blog we also solicited questions from the community, individuals who couldn't be here today or individuals who wanted to get their question ahead of time. So I have some of those, and I'm going to start off with some of those. But Tom, you look like you had a comment to make.
Yeah, on Russ Johnson's remark about managing your own care, that was my initial reaction to reading the Obamacare. It's going to draw individuals into playing their part in care. And learned helplessness has been a built-in part of our system. The Wizard of Oz, you know, we know what's going on. And I'll tell you from my own personal experience, I've drawn at least 100 lab draws in my career, you know, going in the morning and taking blood out of a person's anticubital. And I always tell them, make a fist, let your arm hang down, roll up your sleeve. And yet when I walk in to get a lab draw, I just sit there. And then the technician says, can you roll up your sleeve and make a fist? It's just that's how bad it is. And I think one thing that maybe we need is for people to have some kind of way to keep track of their health care, right in a loose leaf binder or maybe down the road electronically, so they can participate more fully in their care.
Absolutely, thanks, Tom. You know, and there are big components, and I think as many of the panelists have mentioned, it's not the final solution by any means. It's a good bill, and we're on a pathway. I really appreciate Russ's point on that approach. I think we're on a pathway, but I don't think we have the end-all, be-all to health policy, health legislation, health solutions in our country. And that's partly of bringing community together today, such as we have. So you may have different perspectives. Again, you may have different ideas of what needs to be in legislation. The reality is that it is the law of the land. It is the legislation. There were provisions that were effective immediately in 2010. Some of the big provisions come up in 2014. It's been phased in over 5 years, and we're going to see some big changes next year as well, including what were termed as the exchanges when the legislation first came out, but I like the comment of the marketplace, because I think it's going to turn the health insurance market into something that we saw in car insurance once upon a time. Because now with the Affordable Care Act, health insurance can be sold across state lines, which is an important provision. So let's start it off. One of the questions from the web. We're trying to display some of the myths, or maybe reinforce some of the facts that are a part of it. One of the questions was, how well does the Act cover small businesses and small employers? I know small business with 12 employees. Well, I need to contribute to the high cost of health care for my employees. Who would like to start off with that one?
It's a great question. The Affordable Care Act actually was set up primarily to help small business. But the first thing I need to say is that small business if you have under 50 employees, you are not mandated to buy insurance. Now, if you do choose to do that, there are tax credits. Currently, it's 35% of your premium that you can recoup, and in 2014, it's going to be 50%. And there's a way that you can figure that out. You have to have it's for 20 employees or less, and an average income or average salary of $50,000. So that's the start. They're trying to take it up to 100 employees soon. But at this point, many people have been able to get that tax credit. So again, if you have less than 50, you're not mandated to buy insurance. But we know that if you're able to provide insurance, you attract a stronger employee.
I think the other thing that's important, somebody said, well, I have to pay. The question also said, well, I have to pay for the increased cost of health care. And I think it's important to recognize that there are cost savings elements in the law as well. And so eliminating the cost shift by getting everyone insured and by increasing Medicaid, it is going to actually reduce the premiums associated with purchased care, because you'll no longer have to pay that $1,000 a year to support the uninsured. And as we back those out, and there are other savings associated with the Act, the actual per premium cost in Colorado is estimated to decrease by 2019 by at least 5% and as much as 17%. So if all of the parts of the Act work together, the premium, now I have to say average premium, the average premium is actually going to go down.
One thing I will add as a part of it for small business owners, if you do, as the entity or the individual employers themselves, if they do make over $250,000 though, they may be taxed on that as part of this. So that may be where there'd be a small contribution, but employers 49 and below will not have to provide mandatory. Let's see if we can get to some that are here from the audience. Marguerite mentioned about the Colorado Co-op through Farmers Union.
Mm-hmm.
Maybe some of you can mention how some of these co-ops, some of the one through Farmers Union, and also how that will impact maybe small businesses being able to co-op, and will any of it be subsidized? Who would like to tackle that first? Co-ops?
I'll just tell. So the co-op idea envisioned in the Act is actually probably one of my favorite and probably the most underused part right now. But the concept is that groups who can identify commonality can come together and become a purchasing unit of insurance. And that sounds kind of boring, I recognize it, but I want you to think about it. If you take the audience of this room, you're now no longer a small business, right? And if you purchase as a medium-sized business, you get access to lower premiums and competition that you don't have if you're a smaller business or a smaller group. And so the Farmers Co-op, and they got a big federal grant to get started, they have good leadership. What they will do is they will negotiate lower premium prices because they'll be a big player. So now they'll look like a big business, so they'll look like Adams State. And you gotta tell you, you get lower premiums because you're larger and you get that kind of economies of scale. And they share that risk that somebody talked about, the risk of being expensive over a larger number of people. So the co-ops work by making a new purchasing unit. And there's only one that's started up in Colorado, and whenever I go around, Marguerite, I always like to talk about the co-ops because Alamosa could be a co-op. I mean, if the city could actually come together and decide, boy, we want to be a co-op, they would then be a purchasing power with the size of the population, and somebody start to make some real differences. So that's the way I look at them. Marguerite, do you want to add anything?
I just want to add that the co-ops are actually the public option. That the co-ops are actually the public option that people were wanting. This was a way to bring it forth so that organizations could get together, or people could get together to do that. They will be on the marketplace, so anybody can buy into that. And we're, like Ned said, we're looking at probably having some lower premiums.
Anyone else with the chime in? Okay, another question. If we live in Colorado, can we use the federal health care option if it is more cost effective for any family than the Colorado option? And I guess the second part with this is when subsidy eligibility is 200 to 400% of federal poverty level, what does that truly mean?
The answer to the first question is no. No, there will not be a federal option here in the state of Colorado, so people will use the state-based marketplace. And there will be subsidies up to 300% of poverty. That means that people family of four making up to $90,000 a year will be able to get a subsidy. That'll be calculated when you first go in, and like Gigi was saying, when you enroll, that will be calculated at that point. So there is going to be a calculator that is on the website today. It's not set up for Colorado, but if you go to healthcare.gov, there's a lot of information there. You can sort of play around and see what that would actually mean for you. So, and again, it depends on which health plan you choose to buy and which metal level and all of those kind of things. So there's a lot that is still being put together by the benefits, they're changing their names. So
Connect for Health
Connect for Health Colorado. So that's all being put together. But today, if you go into healthcare.gov, you can find out a lot. You can do the calculator and try to figure it out on your own.
I don't know if it was implied in the message or the question, but another part is there isn't a federal product. There isn't a national product that's being put out though. So the distinction that Marguerite is making is that each state is creating this marketplace, this exchange where private insurance and co-ops will put products onto an exchange with the idea sort of being, as I don't remember if it was Tom who said that like you can buy life insurance now. You can go to a site and you can get 5 bids on life insurance, just like that. And so there isn't, and I think that's an important distinction, there isn't a federal program, a national program that the government is putting forth. The expansion in private and small business is a marketplace expansion. It's commercial insurance. It's United, it's San Luis Valley HMO, it's other people who might form a cooperative. So the other thing that I think is often misunderstood about the act is that it's a government takeover. Well, quietly, a lot of the private insurance are very thrilled about this because they're going to add millions of people into the insured ranks, which they're going to cover. So it actually increases the competitive marketplace for private insurance.
Thank you. One thing I will add is that there is a sliding scale for that eligibility. So individuals on the lower end will receive more. For example, I think for premium, it's about 4% of income. For individuals that are on the lower end, and for people that are closer to the 90,000, it'll be a 99%. Approximately. So it's a sliding scale. It's not the same for individuals who are making $35,000. They're not going to receive, people making $90,000 are not going to receive the same benefit. So there's a sliding scale as you make more money for those tax credits. Prevention. Question on prevention, asking if will the prevention aspects of the Affordable Care Act bring down the cost of health care?
Russ was talking about the how our country cannot sustain the level of healthcare cost. We've all known that. And about the ACA being a pathway to seeing some major improvements. Well, I think at the beginning of the pathway is prevention. I think that's what's at the trailhead. I think it's going to take, over time, into the future, a critical mass of us to take better care of ourselves, engage in less high-risk behavior that results in the high-cost illnesses that we've been paying for, that we will continue to see on the rise without that prevention effort on our part. And I think that's the part that the ACA gives us access to. But where it becomes really tricky is how do you get people to make these kinds of changes? How do you get entire communities, cultural ways of life to change? At the same time that we're talking about equity and diversity, sometimes some of those things, at least on the surface of it, seem to run into conflict. But I think, the bottom line is it is going to take that critical mass to make a change in the law.
I also think that the coverage for preventive services will be beneficial. In early detection of conditions, it usually results in less costly treatment. And so I think that we should see an impact in the long run on a decrease. Initially, we may see an increase because people who haven't had the care, who are now coming into the system, will be accessing the care for the first time and maybe in later stages of diseases. But the prevention, it's very important for people to get that care early, to have that detection early, and that will be more efficient for them and hopefully yield better results.
I don't know if the asker of the question may be aware of this, but there is a lot of mixed research on prevention and the cost of care. And in fact, there's a large body of data that show that prevention doesn't lower care, doesn't lower the cost of care. But I think if you dive into that deeper and you look at longitudinal studies about prevention, so a lot of the rap on prevention in the past has been primarily because it's not a good investment if you're an insurance company in prevention, because the average tenure of somebody in a policy is about 18 to 20 months before they change to another policy. And so if you're the insurance company and you're investing in prevention, there's no return on investment. But I think if you look, as Gigi said, if you look at a longitudinal study on prevention, you begin to see payback. It's not an enormous payback. It really isn't. It isn't going to save our healthcare system. On the other hand, if you look at quality of life, and you have somebody, as Gigi said, or as Reg said, who catches a disease state earlier, it's not the same kind of a payback. So the prevention data is a little mixed. That's a really good question. But if you look at it over a longer period of time, and if we hang in there as a country, frankly, we have to with some of our lifestyle issues, or no matter what we do, we're going to go bankrupt. But I think the prevention pays back over a long period of time.
May I add to that? Please. I'll do it real quickly. I just want to let you know that there's a huge list of preventive services that are available for no out-of-pocket cost. And those include some big ticket items like colonoscopies and mammograms and things like that, that people before would say, I can't afford that copayment. Even though you tell me at 50 I need to get one, where am I going to get the $300 or $400 to do that? So today that is covered. The other thing is that we actually saw insurance companies saying before the Supreme Court made their decision, insurance companies told us that we're going to keep those preventive services available because, in fact, we are saving money. And so they said, regardless, it's going to happen. One of the interesting things that was before the ACA came into effect was that smoking cessation treatment or classes were not covered by Medicare unless you already had a diagnosis of throat cancer, emphysema, those kind of things, which is ridiculous. Today, no longer. If you want classes, you get them, no out-of-pocket expense, dietary classes, all those things that before, I never understood why physicals weren't covered. Well, now that's in there. And then on top of that, there's another benefit. It's called a wellness visit, where we used to see in the real boutique, high-end insurance companies, where you could go in and talk to your doctor and kind of get a plan for the year of what you wanted to do. Now that's included in all of these. No out-of-pocket expense for that. So your doctor can say, you need to have this test or that test, because it's not like you can just go in and say, I want all these services. It still has to be prescribed by your doctor, in consultation with you, given your age, your gender, and all of that. But I love this piece, because I think when we're done with all the reform, it's really the prevention and what we do for ourselves to keep ourselves happy that is really, and healthy, is really going to count.
Tom, I know you're a big prevention advocate, and I'd like to bring you in this discussion just to offer, if you could offer a little bit of perspective of what you think prevention is going to do, especially in bringing down the cost of healthcare.
One of the big ticket items for Medicare, and I'm sure Marguerite knows, is diabetes. And Dr. Kalange and I were just whispering, catching smoking after the fact doesn't make much sense. And neither does catching diabetes after the fact, because it is largely if not a preventable, you could certainly slow down type 2 diabetes by lifestyle changes. And the medications are getting better too. I don't want to discount what the pharmaceutical companies are doing. They do good work on that front. But another example of where prevention will make a big dent in people's quality of life and also in the federal budget.
I was really wrestling whether or not to disagree with my esteemed colleagues. So
That's what the panel is, part of different perspectives, so please feel free to do so.
So I actually was on the task force that generates the list of services that are paid for with no first dollar coverage, and the task force that does that did it not based on any dollar amount. So that was never part of the equation. It was just whether or not it saved lives. So as far as clinical preventive services go, you don't do them because they save money. You do them because they save lives, and it works. So I don't want to undercut anything he said other than that's why you do it. Mammography is not cost effective. It works. I mean, cost beneficial. It saves lives, and that's why we should pay for it. And that doesn't take anything away from it. But what I want to say is that prevention does save money, but we have to rethink it. Not necessarily so much from delivery through the healthcare system, but delivery through the change in our behaviors in our communities. So when you talk about diabetes prevention, that's not a drug. That's not a prescription from your physician. That's not something you really need to engage the healthcare system for. That's having a safe community with walkable sidewalks, having things that promote activity, having a cafeteria on campus that promotes learning how to eat healthy as a young adult that you'll carry on into your habits going forward. It's really it's not smoking. I mean, that's a great one because no one needs to smoke. And there's if it makes you feel better or not, there are no positive health effects associated with it. So the whole thing, I don't want to lose sight of the fact that the community will answer the preventive activities that are going to make the hugest difference in terms of costs. Because if you keep your weight down and you don't smoke, you're physically active and you eat right, you will have less chronic disease, you will live longer, better, and you may never have to go see a doctor until it's time to shuffle off this mortal coil. So I just had to put in a pitch for those things of health that aren't associated with the healthcare system. And I'm sorry.
May never have to go see a doctor, said by the medical doctor. I mean, we still want to encourage, you know, preventive visits, there we go, preventative visits. But I think that's a very good point. Some of the services that we do, the impact isn't necessarily always about cost. It isn't always about revenue generation. It may be about saving lives or making people healthier. I think it was Russ that mentioned earlier in his remarks when he talked about the impact. People that have health insurance are more productive, are healthier. Well, if you keep healthy people and they work, they become more productive members of society. And so there may be an indirect benefit that we receive that's not directly tied to a cost. I think it's very important. I'm going to tie a couple of questions together from the audience. First of all, how will the Affordable Care Act affect medical staffing, doctors, nurses? Someone mentioned that it is difficult for providers. I think, Gigi, you mentioned that, or keeping providers here. And to move that along, then with another comment that was made, or question that was made, is the Affordable Care Act moving us towards a European style of healthcare coverage? Because they do have universal coverage in many countries. Is that part of this pathway? And part of that pathway that they have in European countries is they pay for medical professions up through medical doctor and through PhD. So I don't know who would want to start tackling that first. The medical staffing, but then also, should we pay then to have more providers as the European model does by paying for their medical education up through MD or PhD?
I'll start. I'm sure my colleagues will continue. The Affordable Care Act actually provides $10 billion into Health Service and Resource Administration for more faculty, for more loan repayment slots for the National Health Service Corps, for faculty to train not only doctors but nurses and social workers and psychiatrists and dentists and the whole compendium of medical professionals that we need. And so when I left Valleywide, we had about 4,000 National Health Service Corps doctors across the country. Today we already have 10,000. So people will tell me, great, we're all going to have a card, where are we going to go? And we're listening to that, and that's why we're investing money into facilities and getting more people out into the hinterlands. We've also, within the Affordable Care Act, have set up a provision so that nurses can set up clinics. Master's level nurses can run clinics. We already have one here in Colorado that is one of the first, and we're looking at doing a nurse residency program at the University of Colorado. So we're really on a fast track to try to get more professionals out there. The behavioral health piece is essential. We have a real lack of behavioral health specialists. We need to do better there. In answering, are we really on a path to universal health care? No. This is a uniquely American idea. It brings in the private, the marketplace, all of the insurance companies, and it marries that, brings them and makes them a part of the whole reform piece. If we didn't have the insurance companies involved, yeah, then maybe you would see a different set of plans going forth. But that's why a lot of people hate the plan, because they don't think it went far enough. A lot of people wanted universal coverage, and so that's why you see people on both sides not real happy. It's not the perfect bill, but it is a good start.
I would add, just from a local community, I think the impact of the Affordable Care Act will actually make our ability to attract and retain physicians stronger. And going back to the earlier premise, where so many people in our community now don't have insurance, our physicians and our mid-levels are seeing those patients. We're just not getting paid for them. And so what the Affordable Care Act is, it brings people more people into a typical insurance structure, and I think allows us to be more competitive with our providers, and allows those in solo practice to continue in solo practice, and for Gigi and I, who recruit and employ a lot of providers, it strengthens our organization's ability to do that. That's my take. I don't know, Gigi, if you have another thought.
No, I think I would concur. I think, though, it may also be challenging because we know that there is an inadequate number of physicians in the U.S. to see all the patients that might be coming on board, and so that is going to be a challenge. And I know that there's some wrestling going on with the National Health Service Corps, funding, and so you know, we need to keep encouraging our legislators to support, further support for education and loan forgiveness and things that will incentivize people, providers, to come into rural communities. We've also looked at having an educational program here, but it's very costly. And we have to have partners, for example, in the hospital, and so the impact on them would be an additional cost. But we're still looking at it, we're still talking about it, we're still looking at what's in the act and what's, maybe become available down the road to do training of physicians here. We are all currently having physicians, pharmacists, nurses, mid-level nursing people do rotations in our facilities and as part of their educational program. And hopefully that will help alleviate some of the problem by teaching some of these physicians that, hey, this is a great place to live. It's a great place to raise kids. And we've had some successes with that. We've had some providers that have come and stayed. So.
Thank you. We haven't talked about the individual mandate really much yet. And so I think this next comment question goes to that. One problem or concern I have with the Affordable Care Act is that I am uninsured because my employer does not provide insurance and I cannot afford it on my own. Now I have to go out and find insurance because of the individual mandate. Now will I have to pay a fine because I can't afford insurance if I don't get any? Who would like to tackle that one?
The person that gets paid for doing that.
I think they're directing me down to this end of the table, Margaret.
So again, I'm sorry, I was telling Russ that on Friday I just heard that a bill is being introduced in Colorado State Legislature to form a rural residency program. It's exactly what we've been working on for San Luis Valley, so hopefully that's going to pass and it'll get funded through the state legislature so we can do that. So this question is
part of this on the individual mandate. It's looking at individuals who don't, their employer doesn't provide insurance, they don't make enough to really go buy insurance on their own. So they're saying, am I going to get penalized now because of the individual mandate if I don't go get insurance?
There are provisions for people who flat out can't afford it, and those things could happen. What the bill says is that no one should pay more than 9% of their income for health insurance. And so for people who are at that very low income and aren't part of Medicaid or for whatever reason cannot afford it, they're not going to get penalized. But that's something that will happen through the calculation. The IRS will be a piece of that as well. So there, again, for the poorest of the poor, for tribal members are not going to get penalized for not having insurance, but they've tried to look at the most vulnerable populations and said we're going to do everything we can. That's why they're going for Medicaid expansion. CHIP is still there. All the subsidies are there. And again, someone going on to the marketplace at a very low income should be able to get a substantial subsidy. But if they don't, they will get penalized.
As part of that, please don't forget is that they're increasing some of the eligibility for some of the programs. So Medicaid is increasing, so that may help some of these individuals. In addition, there are the tax credits we mentioned before, that there's that sliding scale. So this Affordable Care Act is really working to help the working poor, if you will, of our country. It'll cover many of those individuals and help them subsidize through those tax credits. Again, it doesn't come at the end of the year when they're filling out taxes. It actually comes at the time when they're enrolling for the insurance plan. So they never actually see that money directly, so they can't go off and buy a Ferrari with that money. The money goes directly to pay for their premium for their health care insurance. So that's important. And I think that's what 2014 is really going to bring about. It's going to have to, people are going to have to experience it. They're going to have to realize what does the marketplace look like? How do these co-ops actually work? How are these tax credits actually going to take place? And because it's so unfamiliar, I think that's why there's that anxious nature of what is going to happen, and they hear about that IRS penalty.
I know that we are, planning to develop information points and help people with enrollment. I know the hospital is, and in fact, we're collaborating on a grant to bring more resources to help with this education of the individual citizens. Some of it's a little challenging because some of it we don't have the answers to yet. But we're trying to stay on top of it. We're trying to get the resources in place so that we address, we have resources in each of our communities that can answer these questions and help people enroll when they're eligible for, and determine, are you Medicaid or are you insurance? And you know, what kind of tax credits can you qualify for? And I suspect in this valley, people are going to fall into one of the two with the tax credits pretty readily. So, either Medicaid or tax credits.
I agree with the expansion of Medicaid, the tax credit. So there is opportunities. So if you do feel you're in that position, I mean, first of all, we are a health education, or our intent is to promote health education, especially here at Adams State. Come by and visit me in the School of Business. I'd love to. I won't pull you into class every week, I promise. But I'm happy to have the conversation to see how does the Affordable Care Act help you. This next question is looking at local data, and I know several of you work with some of the local data or are familiar with the local data, is what does local data say about the local need to increase access to health coverage? And Reg, I would like to bring you back into the discussion if you would, and maybe give us some perspective on that.
One of the studies that I referred to in my introduction was the San Luis Valley Community Health Survey, which was done in 2010. And one of the findings of that study, there were a set of questions, a total of 200 and some questions that covered a broad range of health conditions, but also access to health care was a major section. And one of the findings was that, and surprisingly, 73% of that sample of approximately 1,200 people said they had some kind of health care coverage, insurance, if you will. So that leaves a 27% who are saying that they did not at the time, and then also for a previous 12-month period of time have coverage. Their reasons were numerous, but as you can imagine, at the top it included cost, loss of job, family member who had lost a job that provided family coverage. But it was surprising that it was actually that high. I don't know what the rest of you think.
So the Colorado Health Access Survey tagged it in 2011 at 23.6%, which is lower than the number that you had, but not so much that I would say either number is wrong, and both numbers are really high. When we apply that to the population of the valley, so how many people live in Alamosa?
50,000 in the valley.
So when you apply that number to 2011 to the population, it meant there are 12,000 individuals, 12,200 uninsured in the valley. So think about a city about the size of Alamosa with no one having health insurance. That's a lot of people. And so when people often ask me why did we do the Affordable Care Act? What problem is this trying to solve? That's the problem it's trying to solve. And then you have a healthcare system, a hospital, a provider group, I think of Valleywide more than an insurance company, that really is going out of their way to figure out how to provide services, needed services for those groups, as well as public health, and a lot of other entities around the city and the county and the community. I think the Affordable Care Act exists to try to bring new resources in to address those needs. Because the impact of not having health insurance is big. There'll be about 630 people who died in Colorado last year because we didn't expand Medicaid last year. And that's really the cost of not expanding Medicaid. It makes not expanding Medicaid the the 10th largest cause of death in the state. It comes number 10. Replaces flu. Interesting. And so thinking about being able to do something at cost neutrality or cost savings, which is what the governor has told us, that would save 629 lives a year, more than the number of women who die from breast cancer in Colorado, more than the number of people, men and women, who die of colorectal cancer a year. Be able to do this one thing that won't cost us any money and bring more resources into the valley and save people's lives and improve the healthcare system. That's what the ACA is supposed to do. And I know I sound, like a proponent, and I'm not really trying to talk people into it. I really like to talk about the impact and the costs and what you're buying for the costs. Because it's rare that you know what your tax dollars are going to buy. And in this instance, they're going to buy health, longer life, and a more robust economy. And I honestly really believe that. So.
Just a point of clarification, no, Valleywide is not an insurance company. That's SLV HMO Colleges.
Somebody called it an insurance company.
Beg your pardon? Oh, okay. Well, we're not an insurance company, and we're a provider of healthcare services. But one of the things that I'm hoping is that we'll see more insurance companies look at coming into the valley. Because, really, as employers, large employers, we only see about the same three insurance companies that'll bid on our contracts. And so, hopefully we'll see some more too that'll give more options. We know that there's some smaller insurers that come in with a very, very high deductible. And many of those people we really consider underinsured. So they may say they have some kind of insurance, but they have a huge bill to pay still for healthcare services when they need them.
Yeah.
So this should help with that as well.
And I think that's an excellent point. We always turn this discussion about who's uninsured. We sometimes don't talk about the underinsured with the high deductibles or not covering essential services. One key aspect under the Affordable Care Act is that every health plan is required to have essential health benefits. And so I think that's important that we recognize that for health insurance. Next question. Will anything be done with tort reform? There are many lawsuits where lawyers make tons of money. So what about the cost of... This is what you sneak this question in, Tom. Are you going to answer this question? Okay.
Over the transom.
So, and we do have an attorney as part of the panel, so I don't think this was directed by any means there. But how
did that kind of practice?
how does malpractice lawsuits, how do those impact, the cost of healthcare, and how does ACA acknowledge that, or does it address it in any means? Who wants to start?
A lot of patients, when they're anxious about getting a surgery or having something done, will say, I'm going to, I can always sue, So they're kidding, but in the back of everybody's mind in this country is that you can redress a grievance by going into court. And it's a very good thing, and they don't have that in other countries. Lawsuits are controlled in the healthcare systems. The flip side of that is that the thought that a doctor in the back of his mind that he might get sued and that would push up his liability insurance may tend to make him write for more testing than is necessary. It's always a close call, but that's the flip side. Well, I'll leave it at that. Those are the two sides of it.
Let me answer the first part of your question. So the malpractice system does add to the cost of care, and it's beyond just malpractice premiums. It's setting an environment in which a provider orders more tests in order to decrease in their mind the risk of being sued. And so I'll use a real graphic example. No one ever gets sued for doing a C-section. So if the physician has the potential of, or any provider, of a vaginal birth, and there's a little sign of trouble, and the baby might still be delivered vaginally without surgery, safely, all of the incentives are to do an operative delivery. Because no one ever gets sued for doing a C. You only get sued for not doing a C-section. So that's a malalignment of services. And that's just, I use that example because it's the most dramatic. But now start to think about, you have a headache in the emergency department. Boy, I probably am not going to get sued for ordering a CAT scan. And yet if I miss something bad, I will get sued for not ordering a CAT scan. So all of the incentives are aligned to do more, and they're supported by the legal system. The ACA does address malpractice tort reform, but I will tell you in Colorado, the ACA uses what Colorado has done as all of the changes to do tort reform. So we changed our law back in 1989 to put caps on coverages and a lot of other elements in response to the increasing costs and how that impacted rural Colorado. And I know that because I was there and I was part of that. And we kept those in place now until just the last couple of years. But when the federal government looked at tort reform, they looked at Colorado and replicated those issues. And so we're not going to gain anything in our state. And we'll just have to continue to kind of say, isn't there a better system where we take care of the patient's medical needs and don't necessarily have to invoke the healthcare or the legal system? And I don't have the magic answer. I mean, I understand that being in state government, I was around trial lawyers for a lot of time, and they talk about making the patient whole, which is different from taking care of the problems that you cause. Those are two different things, and the doctors and the lawyers can't ever seem to talk about the same thing. It'd be nice if at some point we talked about fixing the system, getting rid of medical errors, not letting them happen again, and making sure that at the very root we take care of the patient.
I also think that this could have a benefit in the fact that at least people have an option for coverage. And one of the reasons that you have some large decisions is, or awards is because people have to be able to pay for the results of malpractice. Unfortunately, there is a very high rate of malpractice, and this is not the legal malpractice, but you find, I mean, the data shows high error rates. One thing, maybe, like with electronic records, where we can start monitoring this information and start aggregating it, and we're starting to do it already, we can go, oh, we need to address this as an issue. Hopefully that will help to address some of the quality issues. The other thing is I think we need to educate patients. You don't have to have an MRI every time. I remember one time I was going to have knee surgery, and I said to the surgeon, he goes, well, I want you to have an MRI on your knee. And I said, well, what you still have to do is, even if the MRI shows this, will you still scope my knee? He says, oh yeah, I'm absolutely scoping your knee. And I said, well, then what's the point of having the MRI? And so, but people in this country think that, well, I've got to have a CAT scan for this, I've got to have an MRI for that, I've got to have back surgery automatically. There's a certain amount of education that there's going to be a lot of education we're going to have to do for patients and citizens, so that they realize that they don't have to go in and always have all the things. I mean, one of the, some of the best treatment for backaches and stuff is good old massage, physical therapy, massage, all that kind of stuff. I'm not saying that we should go totally and leave the allopathic health system, but because I think there could be some bad outcomes if some people who choose to ignore that. But I think we still need to do a lot of education of our citizens, and hopefully, with the coverage, we will reduce the need for having to pay the large judgments.
Is massage covered under ACA?
Physical therapy is.
But physical, okay, good deal. Well, I know Mr. Russ Johnson has to leave us a little bit early. We had scheduled this to go to 4 o'clock. How's everyone doing on time? We go another half hour at least? Add some more questions? At least, okay, so we'll keep going. Thank you, Russ, for joining us. But that doesn't mean everyone else has to leave too. But for the diehards who want to stick around, we'll tackle a few more questions. I think this is an important point to bring up with this next question. Small business, and we hear this a lot. I think there's a myth about small business. Small businesses are under the impression the requirement to provide health insurance for employees will break them. So it will close their business. So I think we want to emphasize that small businesses, 49 employees or less, are exempt. And so that's what we want to highlight. But as part of the question, I do want to discuss what I have been seeing is employers that might be right around that 50 employee threshold. Do you see some employers not going beyond that 49 employee to stay exempt? Or I've also read in a Wall Street Journal recently where there was a small franchised McDonald's working with a neighboring franchise, Burger King, who would hire a morning shift at part-time. And in the afternoon, that same shift would then go to the Burger King in the afternoon. And the Burger King morning employees would then go to the McDonald's in the afternoon. So they kind of just keeping part-time employees to try to stay below the threshold. So I don't know if anyone would want to tackle that one.
So I will just say one thing. So I thought Marguerite might jump in there.
I was shaking my head.
I'm going to talk from the experience of the passage of the exchange bill a couple of years ago. The reason Colorado passed the healthcare exchange bill was because it was supported by the small business majority. That's the only reason that bill got passed. That group in Colorado, led by some folks, said, you know, many of us want to be able to provide health insurance for our employees. It is a real desire on our part. And we see the exchange as providing some lower cost ways to do that, ways that we might actually be able to afford. So we gloss over that a lot. I think I don't want to underscore the onerous costs associated in a small business with providing health insurance. That those are real, they're dramatic, they kind of say whether or not you can continue. But I think it's also recognized that most small business employers, if they could, would like to do it. And if we can be successful through subsidies, through tax credits, and through addressing the cost of health care through the ACA system itself and bringing down costs so that it makes it more attractive and potentially doable by small employers, that's a home run. So I think that if I was a small employer, I'd still be sitting back watching, right? I want to see the exchange open, Marguerite. I want to look at the price tags associated with that. I want to do the calculus of what's my penalty for not doing it if I'm above 50 versus what it's going to cost me extra to do it, and continue to think at what point I think I can insure. Because if we're all competing for a workforce, I think healthcare insurance is going to become one of those things that I might look at it as a worker, as I'm going to go to this company and not that company.
And as a business guy, I love the competition. I welcome competition. I think more competition pushes our prices down and provides higher quality of products from a competitive marketplace.
Yes, there are going to be impacts on small employers. And again, as everybody said, if you've got less than 50 employees, you know, the employer is off the hook. If you have less than 25 employees in full-time equivalents, then there's another benefit thing. One thing, by the way, it's not number of bodies, but it's full-time equivalents. And so that's an important factor to look at. And so that's where they may be gaming the system. But if they have less than 25 full-time equivalents and the average wage is less than $50,000, as Marguerite mentioned, the employer may qualify for a small business tax credit of up to 50% of the employer paid premium for 2 years if purchased through a small business health options program called SHOP. I think some of my staff are surprised I know that. But yeah, but not until 2014. It's not this, this is all rolling out. But if the employer does not then meet this requirement, The employees could qualify for a tax credit or subsidy to buy coverage on the exchange. If the employer will then face a penalty of $3,000 per FTE receiving the credit, or $2,000 per total FTE, excluding the first 30, whichever is less. So really, I think there's going to be a push to get employers to be purchasing, paying premiums. But the tax credit, I think the credit will be very helpful to them.
You know, we're in a phase right now of a lot of education, and so, you know, that's why it's so great that we're doing this today. But one of the groups that's going to start helping us a lot with small business is the Small Business Administration. And they're really stepping up to come to communities to answer those kind of questions, to sit down with businesses and help you work through what works best for you. And you know, as the question indicated, there will be a lot of groups that try to not do the right thing, but in the end, you know, like Armando said, we're going to see that those folks or those organizations that offer insurance are going to get the best employees. So, but again, you know, small business, this is to help them, because in the past, the same plan that a large company would buy cost a small business 18% more, just because they were small. And so that's the kind of thing that we're trying to combat against. But it's going to take a while. You know, we've got all of this time now to get ready. We've got in June, it's going to start getting much more active. You're going to see more information when you go to Google and you ask anything about health insurance. Everything's going to pop up and direct you down the path to start enrolling and getting ready. And then by October 1st, people can actually enroll and get ready for January 1st. But we don't want to do too much right now, because then people will say, well, where's my insurance? You know, I did all this stuff and I'm not insured. So this is truly the educational period. June is more the anticipation, and then October 1 is when everything will start really getting fast-tracked.
Thank you. And point of privilege as moderator, I might add one part to it. If businesses start, I think, gaining that 49, 50 employee threshold, they're going to be limited on what they're going to be able to produce. So at some point, their revenue generation is going to be limited. So from a business standpoint, if you want to make more at some point and increase your capacity, you're going to have to add more employees, and it may be beneficial then to add the insurance and meet the insurance beyond that. This next question I probably directed towards Marguerite with the navigators. You mentioned the navigator, and if you could clarify that a little bit more, because we had 2 or 3 questions about that. Also, the $120 million that you might have mentioned that comes from the navigator program, and how will that be structured? If you could just maybe clarify that a little more for people.
This is a very popular item or issue of discussion these days. The big difference that people need to understand, because I think the biggest confusion comes between what is a broker and what is a navigator, and how do the two work. The broker is the person who will actually help people purchase insurance. They can sell insurance. Navigators are not allowed to do that. Navigators are more like case managers, they're educators. They will help people down the path of what they need to do, but they will not be involved in the actual purchase of the insurance. The law states that there have to be navigators, and that they don't have to be licensed either. Several states have tried to pass legislation that says navigators have to be licensed brokers. That's actually against the law. So Colorado is going to spend $20 million, not $120 million, but $20 million on navigators. I can't remember if the number's 300 or 600. It's a huge number of people that will be spread out throughout the state working on that. But, you know, of course, there is room for brokers. We need that. But what we're trying to do is help people understand, what is a premium? What is a deductible? Why do I have to pay it every month? Because that's a lot of the education that has to take place that navigators are going to do. And a lot of the questions you've asked today are the things that navigators will be trained to do. They have to have 30 hours of training. They have to pass a test to be able to be a navigator. And so there will be nonprofit organizations having navigators. I really encourage any of you, and also private or entities can also apply to have navigators on staff. So it's truly all comers, and you'll apply through the Colorado marketplace.
So, Marguerite, I think the confusion comes in the use of the word navigator, because it means something else too, right? It means the patient navigator, not the purchaser navigator.
Right.
And so what the ACA does address patient navigators from the standpoint of people that help patients navigate the healthcare system. But that's more in a pilot program and demonstration and support. These navigators are helping people navigate the healthcare marketplace,
Yes.
how to buy insurance. And so that's where, Martin, I think there's some confusion about,
The time navigator.
you know, which
role.
navigator are we talking about?
Mm-hmm.
And I think there's continued a little bit of confusion over that.
And there are assisters too.
And I thought that was the word they were going to, was the assisters. So I just want to make sure people are thinking about navigators the same way.
Yes.
But the point is, there's individuals wanting to help other individuals, direct them down the right pathway, help them understand this complex process. And because it is going to be a huge impact and new legislation for everyone to become familiar with. So I think that's the key reason of why we have those individuals or those roles in place. Outcome-based. A couple questions on outcome-based, and will the funding be based, will it be directed toward places that have good outcomes, or places that have, or less that may have negative outcomes, or what will we reward programs that do have negative outcomes? Particularly, this question was around mental health, and I know we have a clinical psychologist here with us today. Looking at the outcomes sometimes that are associated, are sometimes mixed, especially in mental health. Are we just throwing money towards programs that don't always produce the best outcomes? And how are we going to change that funding structure? And especially being outcome based. Who would like to address this one first?
Again, Colorado has been at the forefront of this, looking at accountable care organizations. But what Colorado did in preparation for these accountable care organizations is to set up accountable care collaboratives that are specifically for Medicaid patients. The accountable care organizations are for Medicare patients. And the idea being that a group of providers, not just medical providers, but we're looking at nursing homes and home health agencies, and those folks should all get together to say, this is a group of people that we're responsible for. How are we going to make sure that they attain the highest level of health care that is possible? And so it starts, with knowing who your patients are and taking care of them, and then watching the readmission rates and things like that from the hospital. So where the funding comes in is that if a patient is discharged from a hospital, and that's already happening now, and they are readmitted for the same thing that they went in for in the first place, the hospital will not get paid for that second visit. So that's where you may have heard that $716 billion are being taken out of Medicare. It's partially that hospitals are not going to be paid for doing the same thing over and over again if it didn't work in the first place. So the idea is to make sure that patient goes home with somebody following up with them. I visited an internal medicine practice in Denver where they partnered with the community mental health center. So every patient in their practice got a visit from the mental health therapist, whether they had a behavioral health issue or not. So that person was talked to when they got home. That therapist called them to make sure that they were doing okay. The rate of readmissions just dropped dramatically. Again, it's just somebody following up and making sure that patient is okay. The other thing that's going on is that people in the hospital are going to have a patient satisfaction survey that determines, again, a piece of how much money the hospital gets paid. So you are no longer considered the gallbladder down the hall, the broken leg over here. You're a patient, and you've got a name, and you've got the ability to fill in the response, the survey, to say, yeah, my hospital did take good care of me. They turned off that dang light, they quit, all these things that, and it's got to be within reason. But hospitals are going to also be measured against those kind of criteria, and a piece of what they get paid will be on that. Now, if they do a really good job, they're going to get bonused. But with the accountable care organizations, and we have, I think there's 2 in Colorado, they're just starting to come up. they will be bonused again. They'll look at how much money they spent 1 year for 5,000 patients, and then they'll look the next year and say, did you save money? Did you go over? You know, what happened? And kind of look at how they manage that group, and then pay them based on that, bonuses or cuts. Because we waste so much money. Another piece of that $716 billion is in waste, fraud, and abuse. And so again, you know, if too many tests are being done over and over and they only needed one, they're not going to get paid for the second and third. That's why electronic health records are so critical. So that if I had an x-ray at Pinellas County and then I came up to Alamosa, they don't have to redo it. They can show the doctor here what they saw in Pinellas County or Rio Grande, same thing. So we're trying to cut down on that's the waste. The fraud is another huge piece, you know, that the Secretary and Attorney General Holder have been able to recoup over $11 billion, put that back in the Medicare Trust Fund, of this just plain, you know, people, thieves who have been stealing Medicare money, who have set up fake practices, who then bill and then would leave, you know, by the time Medicare would go chase them, they'd be gone to set up in another state. Again, we're doing more than any other administration has ever been able to do in combating fraud. And so it's not, no benefits are being cut, it's just watching fraud, waste, and abuse, and looking at how are we better taking care of our patients.
One last quick comment also, we're seeing insurance companies also starting to pay, looking at quality indicators that they have. And so we're even seeing it on the private side.
You know, the reason that we do research is to inform our practices, to inform our teaching faculty who teach our practitioners and providers, and to inform our practices about what works and what works best. So psychological behavioral health care research for many, many years now has already been going in that direction. And I think it's, as Marguerite was saying, I think where you see the impact is on probably the waste more than anything else, is in providing for approaches that stand a better chance of working, and that's what we want to invest in. But I guess I'm either just uninformed or it's not happening, that those outcomes or the outcomes of those practices are going to be tied to recommendations for whether patients should be going to such and such a provider, individual provider, or provider organization for the mental health and the substance abuse care that's provided in the essential benefits of the plan. So, yeah, I'm not sure that it's that specific. It will be. Okay.
Thank you. Well, we're losing panelists as well, so I think we're getting close to the end. But I would like to stay for just a few more minutes and do a lightning round. And each individual, if we could just go no more than a minute to kind of answer some of these final questions. But before we get to that, just one question that did come up from the audience. Individuals who are on current programs, definitely move on down, get a little more cozy with these guys. You got abandoned at your table. Individuals that have current benefits through, maybe it's Medicare, maybe it's Medicaid, maybe it's through private insurance. How are the individuals who currently have insurance going to be impacted by the Affordable Care Act? Is it going to increase their benefits? For example, dental with Medicare, vision, is it going to impact their benefits, or individuals who have that coverage, is it just going to remain the same? Anyone like to address that? Agree?
It'll stay the same primarily, unless for some reason that the individual plan decides to increase the benefits. But people who have insurance now, who have Medicare, who have Medicaid chip, it's going to stay the same. Now, I want to say that the expansion on Medicaid is not going to include long-term care services. That's just such an expensive benefit that that's not going to be part of the new plan. So, you know, but other than that, people shouldn't see a change.
Thank you, Margaret.
What you just heard, I think the next set of policy or legislation, long-term care. It's one of our key areas we've been talking about even in our health policy class. I have some of my health policy students here today. What's going to happen when we have all these baby boomers hit? And so that's going to be a big impact for everyone to keep in their mind, and especially for my students to keep in their mind. What are they going to do about it, right? Okay, lightning round. We're going to figure it out. Yeah, I'm talented students, so we will. Lightning round. No more than a minute. Everyone's going to get a chance. With a prevention focus on healthcare, do you think future premiums will be driven by how healthy your lifestyle is or how risky your lifestyle is? For example, healthier lifestyles pay less in premium, riskier lifestyles pay more. For example, those who smoke pay more, those who are obese pay more. Will they, or should we say, should they, by your perspective? Only a minute. And I think the Affordable Care Act does allow for smoking to pay more, right? It's the only condition though, right? I believe it's the only condition. But smoking is allowed. Insurance companies are allowed to charge a higher premium for it.
Yeah, hard to do. It's hard to get a truthful answer out of people, I know, from interviewing a lot of patients. And but any disincentives we can build into the system to get people to eat better and exercise would be good. I don't know how to do it though.
I don't see it on the immediate horizon other than smoking.
I think some of our research also gives us a model for how to do it in terms of responding to Tom's comment. We have a framework that is being tested in certain settings that has promise for other settings that facilitates a change process for people in their choices, their behavior, and that has implications for primary and secondary prevention. And that I could imagine, based on what Marguerite was saying about the mental health and substance abuse part and outcomes, could very well get tied eventually to cost of premiums. But again, it's one of those things that I know we have some resources for it, but I don't know that it's already tied or how soon it will be.
I don't think the federal government is going to do any more than go beyond age and smoking status, but what I'm seeing is individual companies doing that with their employees, and they're setting some standards about healthcare status and how much they're charging employees who don't lead a healthy lifestyle. And so that's something that goes into the Privacy Act, and it brings up all sorts of issues, but I am hearing a lot of individual companies saying they have to do this in order to be able to have a certain premium, and I think we're going to see more of that.
And you'll see organizations that do have a set premium, and then individuals who are willing to provide more information, such as do a blood draw, like for life insurance, or be able to provide more information, then get a discount or get a rebate from the organization for it. But to avoid the privacy aspects, you're saying you're providing this information voluntarily. So that's how they're kind of maybe promoting healthier lifestyle. Next one, we've heard a lot about the cost. Do you think ACA will really truly help the cost of rising healthcare? It's been rising significantly. We've been at the top for a long time, and the World Health Organization had us rated at 37 in terms of health outcomes. Do you think ACA is going to help the rising cost of healthcare?
Well, I just reinforced Dr. Kalanj was talking about cost shifting, and what that means is that 3 people go into the ER, and one is covered by insurance. His insurance bill is $1,000. Another is on Medicare. They have a group rate. They're only paying $700 for the same thing. Third person doesn't have any money. Somebody's got to pay for that third person. The hospital can only absorb so much out of their general fund and their foundations. And so it's the private insurer who pays for the one who doesn't have insurance, because Medicare is already at cost. And that's cost shifting, and by enrolling more people, that will spread the risk, is the idea.
I think it's a great question. I think it was Carl White or maybe Yoga Vera that said it's dangerous to make predictions, especially about the future. But I've looked at the economic analysis from the Congressional Budget Office, which is nonpartisan or bipartisan. I can't remember which of those it is.
It's nonpartisan.
Nonpartisan. And I've looked at the analysis that the DU Center for Colorado's Economic Future, which is another nonpartisan group, has done just for Colorado. And every analysis that I've looked at says that if we implement the ACA as written, and that's a really important qualifier, that we will save money. The issue is that there are a lot of special interests who are making money on the system the way it is. And they will look for ways to assure, because one person's fraud and abuse and waste and excess use is someone else's profit. And so I think we need that qualifier in there. We have to keep our eye on the ball and make sure we do all of the issues. One of the things, for example, Marguerite talked about 80-20. Its real name is the medical loss ratio, which no one likes to talk about because I don't know what that means. But it means, the medical loss ratio means the amount that's spent on healthcare, which is a dumb way to put it because it sounds negative, loss. No, that's gain because you're getting help. But we've heard insurance companies talk about trying to get states to waive that requirement. And that's how all of the costs are captured in the cost savings. So just remember that we have to do it right. And if we did it right, I believe it would save money.
I'm a researcher and a practitioner, and all of my education, training, experience tells me that as I was reading for the first time the Health Care Act, we look for what sorts of things influence different outcomes, what sorts of variables, what sorts of influences will make this, that, or the other happen. And part of what excited me so much about the Affordable Care Act was that as I was reading it, I thought, well, golly, if anything ought to make a difference, a real positive difference in cost and health and prevention, it certainly ought to be this. Because when you go through and you look at the parts and pieces, you say, if we put all of this stuff together the right way, what outcomes can we expect? And you would say, yeah, I think it's really reasonable to expect very good outcomes clinically and at the fiscal level. So I don't know that it will for sure, but yeah, it should, I think, except for one thing that really concerns me about it, is as we provide more and more health care coverage to more and more people who have not had it, what will they do with that? Will they continue to utilize it in the place of prevention, in the place of, healthy ways of life, of living, so that they don't develop the healthcare problems that then now they have insurance or coverage or benefits to utilize? I don't know. I think that's a whopping big question. It should. I don't know that it will. What will people do with the coverage?
Great. That's a great answer.
Well, I'm the eternal optimist, and I don't think I could be in this business if I wasn't, because I've spent 25 years hoping for the day that people will have access, that they'll have the ability to pay for the care that they need. One of the things we did was open up what's called a convenient care center. It's an urgent care center for all practical purposes. And what I saw in the type of people who would go there was really, what they went for was really based on whether they had insurance or not. And so we'd have people showing up having a heart attack. We had a cable installer who fell out of a tree and broke his collarbone showed up at a convenient care clinic because he didn't have insurance. The person having the heart attack didn't have insurance. They knew that they could get a lower cost of care by going there. However, it was the wrong place to go because they needed to go to the hospital. At the same time, I see people going to the hospital with abrasions, you know, that sitting there waiting for hours, but they had insurance, so they're sitting at the ER. So we've already seen the cost of Medicaid go down, like I said earlier, by 2%. We've seen the cost of Medicare start stemming and starting to drop, regardless of the fact that 11,000 new baby boomers are becoming Dave Savaldi's every day. And so I do believe that we're going to see a decrease. I do believe that as people have the ability to have preventive services, that have the ability to take care of things early on and not have to go into that $1,000 door at the ER, the cost is going to go down. We have to. We're seeing other countries who have been able to do it. We're smart enough. We do have the best care in the world. We just have to make sure that people access it.
So it's nice having such a talented group of individuals that have wonderful knowledge and experience. It's tough keeping them to a minute sometimes, all right? As a point of information, the Congressional Budget Office did estimate initially that it would cost through 2021, from 2012 through 2021, $1.445 trillion. They just reevaluated that estimate last year, at the end of last year, and reevaluated it to be 1.496 trillion. So there hasn't been a significant shift. They do identify that through years 2014, 2015, and 2016, there is a bump to the deficit as a result, but that's a result of bringing people in. But then after 2016 through 2021 and beyond, it actually decreases the deficit burden. And so that's the key thing. But partly it's bringing those new 35 million people who had coverage initially. But the act did include some revenue generation as a part of the offset. Medical, I think there's a medical device tax. There's the Medicare tax for individuals that's increasing in the 250,000. Can people change their habits? Can people change their lifestyles? And can ACA influence individuals to eat healthier or find better ways to be healthier? Especially for individuals who may be poor and can't afford health club memberships, can't afford maybe healthier foods that tend to cost more money. What do you think?
I think it's very hard to do. I think the realistic way is to have a generational approach like we did with smoking. You know, we didn't really get people to stop smoking in the generation that was smoking then, but over the years, the young kids in school had programs, and I know Jenna and Elena have programs in the schools here, and I think Reg does too. I think it's a generational thing.
So I wouldn't expect the ACA to be able to do it. I do think that Colorado and communities can do it. We're empowered, we know how to, the trick is to make doing the good habit easy and the hard habit hard. And changing the culture to say that it's safe to walk, that we encourage physical activity. The school district in the valleys could say, how are we going to figure out how to keep kids physically active? The schools in we found somebody else, Weld County, are going to say, we're going to say no to Coke and Pepsi for vending machines with sugary drinks, no to Pizza Hut and Burger King in our cafeterias. We're going to do fresh food. We're going to actually help change the culture. So, but I honestly think that for that to be successful, it needs to be owned by the community, and the ACA is not going to do it.
Yes, it's possible to change our habits. We do it all the time. We do it every day. The question is, can we engineer it? You know, just because we want people to change their habits, will they do it the way we want them to, when we want them to, how we want them to, for the purposes that we want them to? I think that there are parts of the ACA that are very supportive of change. There's a whole lot of campaign built into the educational campaigns, and that only goes so far for sure, but you know, I think that there are supports there to at least move us a little bit in that direction. I think it's going to be over time, and that it's something that we have to embrace individually and as a culture. And I think if you ask people, I think one of the pieces of the education really has to be, Ned just talked about it, is if we can put some pressure on all the vendors that are making all of this money off of our poor health, our bad health, they will respond. But I think without that grassroots pressure, what reason do they have to respond?
So my answer is yes. And my 9-year-old father didn't want to wear a seatbelt, and my grandchildren won't ride in a car without a seatbelt. So I do believe it's this is having insurance, buying it is going to be something like that.
I have to point one out, one thing, because we talked about reading the law, and I just want to encourage you to, you can download it on the internet. My copy, which I carry out on my desktop, is only 903 pages, which I always like to point out is only 149 pages longer than Harry Potter and the Deathly Hallows. which may be a better read, but still.
So Congress might be the next J.K. Rowling, is that what you're saying? Maybe not, maybe not. I actually have, I think I brought a few copies of detailed summaries that go through each article, each title and article of the Affordable Care Act. So if anyone's interested, I only have limited, I only have a couple. But if anyone's really curious about looking through it, it goes through and analyzes every section, so you don't have to carry around the 903-page version. I think this is only like a 42-page version.
There you go.
ACA, will it be good for providers? Will it impact smaller providers, even like small community pharmacists, small community clinics? Is it going to benefit larger corporate providers? What do you think?
That's out of my league.
That's quick response. So I'm always bemused by hearing by doctors who say they're going to retire because of the ACA, because I don't get that. I don't understand any part of what is the objection. I worry about my fellow family physicians who I love and admire, who are worried about expansion of scope. The bottom line is there's going to be work for all of us. And with 500,000 new Coloradans being insured, we could get there. There's going to be enough work to do, and there's going to be the payment systems in there as well. The ACA, the way Colorado's impacting it, has already increased reimbursement rates for Medicaid patients, which is necessary both to get doctors to take Medicaid patients and to be able to at least, make a living providing that care. All of those things I think will come together. So the providers should see enough work and adequate reimbursement and the ability to focus not on volume but on the outcomes of their patients. And to me, I can't think of a better way to practice.
Generally speaking, yes, for the, I think, psychologists, behavioral health, mental health types of providers. And the reason for that is because those services have now been built into the essential benefits of plans on parity with primary care services, whereas in the past, many of those services were underpaid or underrated or in some way minimized or neglected. So that's the jury's not entirely in on that. It's a good start. The American Psychological Association is happy with it. Yeah.
And they're never happy with anything.
How do you feel about that? I have a lot of faith in the medical profession. I've seen physicians have to go through a lot of different iterations, from going to DRGs and then managed care and all sorts of things, and they always figure it out. And I do believe that they go into medicine because they want to make a difference. They want their work to be meaningful. And when I would work with our providers and we talked about all these quality measures and outcomes, but then I was paying them based on production, I always felt that was really a very confusing thing that I was telling them to do. And so I think that we're finally getting to that point where we're going to reward providers based on what they do, not how much they do. And I have every faith that they're figuring it out. I'm seeing it every day already. So, yes.
And Reg said APA, and Ned said they're never satisfied with anything. My students would probably agree whenever they have to do a bibliography or citations, and they talk about APA formatting. You guys have been my
I
diehards.
should be representing the APA. Nobody appointed me, and now it's on tape. Oh.
Well, now it's going to the entire world, so thank you. You guys have been wonderful diehards here. I want to end on a strong note, an informational note. There's exciting opportunity with moving forward and finding new access options with the Affordable Care Act. As a part of the exchanges and the new reference of the marketplace are the different types of plans. And I was wondering if we can make some discussion, because we haven't mentioned about the bronze plan, the silver plan, the gold plan, and the platinum plan. And those 4 different levels. And if there may be just some brief insight that probably most likely Marguerite or anyone else that would like to mention.
She was trying to get me to talk about that.
Again, I think it's part of the good information, because people don't realize that's what it's going to look at, and part of it's based upon how much coverage, but the bronze kind of starts in with that essential benefits, what's going to cover for screenings, how much an individual is going to pay, and then it's going to work up at a progressed plan, but also a progressed premium.
That's true. So people will have those options of what they can afford and then what it is they want. And I think it's part of that whole private marketplace, letting people make decisions. It's not the government telling you what you have to buy or it's going to be this plan. People will have a choice. So some people are you may want dental and vision benefits and those kind of things. You can make those choices, but it really, the plans really are about how much out of pocket you have to pay. And so that's where you're going to have a choice. You can look at that. You can compare plans. You can compare providers. That I know that was discussed earlier, and all of those things are going to be available for people to make informed choices. And that's really what it's about.
So I will chip in. So I think it's important to point out that because we passed the exchange bill, Colorado is determining what's in those levels. And nothing against the federal government, but
We want the states to do that.
I know you did. I think this is real important, that these are Coloradans with representation around the state and legislative oversight who are choosing what those services are. And I don't always agree with them, but no one ever votes for me, so that's okay. But I respect the process, that the people who know us are the people who are designing that, and that's really important. The consumerism, I know, I like your phrase, learned helplessness. We've made this so, we put the healthcare insurance purchasing over here, and we let our employers do it, and we never look at it, we never think about it. You will spend more time deciding how you want your Starbucks coffee than you will today deciding what you want in your insurance package. That's crazy. We really have to think about bringing consumerism and say, what do you need for your health care? Because then it makes you a partner. It elevates the discussion you have with your provider, be it a nurse practitioner, a physician, PA. Now you're an engaged partner, not a sitting back patient. And it changes that relationship in a way that I honestly believe will make you live longer and healthier. It's much better for you for me to have a patient who says, let's figure out how to make my healthcare work for me, than the patient say, tell me what to do, doctor. Because I'm really, I had a good education at the University of Colorado, but I don't always know what the right thing to do is.
I just wanted to just,
I'm sorry.
no, you're fine. Right on that partnership and a pitch for the behavioral health care discipline on that profession is that's been our norm for ever and a day. Is the therapeutic alliance, the treatment plan is a partnership. And yeah, there's the old school, and it's not so old, and it's not entirely of no use, but of the resistant patient, the one who was uncooperative, and so that's why the outcomes are bad, and so scapegoating the patient, blame the patient. Yeah. But this is also what I think, behavioral health care and psychology have to offer to the ACA is already, a real strong tradition of partnerships. And it's, quite frankly, part of what makes my work with the PRC and the CCTSI as a psychologist so such a joy is the partnerships that we develop and what we accomplish through what we do.
Through those partnerships.
Yeah.
I think that's an excellent final point, Reg, is collaboration, those partnerships, being able to eliminate duplication, some of the waste, that'll help bring about more efficiency. I'm really excited about this. I really think we've seen a case study for this before, and part of that was with car insurance. Car insurance at one time had its limitations in competition. Health insurance kind of has those limitations. Currently, Blue Cross Blue Shield holds 83% of all private insurance in Colorado. I think it was Gigi Darricades that mentioned it'd be nice to get more insurance providers just into the valley. I'm just excited to get more into Colorado, period. So I think that's the exciting part. So maybe one day we'll have a Gecko or Flo or like Little General selling us health insurance the way we do car insurance. But I very much want to thank our panelists for joining us today, coming to Adams State University. Thank you so much.